Committee Room 29. Sound. 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 Committee Room 29, 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 Sound. Committee Room 29. 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 Sound. Committee Room 29, 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 sound. Committee Room 29. 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 Sound. Committee Room 29.
Open to the public. And just to advise members, the committee meeting will be recorded, broadcast throughout Parliament buildings and also online. Apologies, we have a number of apologies for people who are going to be late because of important policing board business, so no actual apologies for the full meeting. Chair's business, just to Notify everybody, the committee visit yesterday to St Francis Hospice, myself and Danny attended along with the clerk and the permanent secretary, so we had a really useful day there, discussing how in the south they're moved to 100% funding on palliative care services, and it'll definitely be useful in terms of our second discussion today on our own inquiry report. Third item in the CLAR agenda, draft minutes. So draft minutes of the meeting held on the 30th of April are at page 5. Everybody content with the minutes as drafted? Content? Okay, thank you. Matters arising? None? Okay, going straight then to item number 5, which is oral briefing from the Permanent Secretary on the Neighbourhood scheme. Can I refer members to page 19 of the pack? And let's hope everybody's outside waiting on us. I welcome Mr. Mike Farr, Permanent Secretary, Professor Cathy Harrison, Neighbourhood Senior Responsible Owner and Chief Pharmaceutical Officer, and Mr. Gerard Cassidy, Director of Primary Care. So, you're all very welcome. Thank you. And we've received your papers. Gonna hand over to yourself for some introductory remarks.
Yeah, thank you, Chair. So first of all, thank you for holding the session. I think it's really timely. We are just at the beginning of going into implementation of the neighbourhood arrangement, so I think the scrutiny is useful. So thank you for inviting us. If I just cover in my opening remarks why, what and how, but it'll be fairly brief, and I'm sure you'll get into the conversation with us as we go through the meeting. I mean, the why of this is obvious, which is that Northern Ireland's really spending on health and care had been accelerating. It has flatlined, as we know, over the last couple of years, but we're still spending over 50% of the budget, and we know with increasing population of older people who use more healthcare as we get older, that the prospect of continuing to ask for more of Northern Ireland's allocation is just not realistic. And also, we would be denying all those kind of areas where, like education, jobs, etc., where they are part of the wider determinants of health. So the solution has got to be different to where we've been before. And to cut to the chase, we've got to focus more on demand and managing people's care earlier, and more standardised and evidence-based in terms of those early interventions, diagnosing the problem and manage them away from our more expensive elements of care, which is in our hospitals. That would have the added advantage of freeing up hospitals for those people who do need care in that sense. So the why of it is really very clear, and this focus of moving care earlier in the pathway, but it needs a structure to enable that to happen. And so, like other systems, we've created a vehicle by which you would effectively have a governance arrangement for all the resources that are out with hospital care, and you would try and manage those collectively, because once you get outside of hospital, services tend to fragment. So we have the community trusts, we have some services in social care which are commissioned, we have general practice, we have community pharmacy, and we have the really important contribution of the voluntary sector. So actually we have a lot of the assets in place, but they tend to be uncoordinated. And as a result of that, we tend not to get the value when we do spend money, and we don't really have an easy platform for shifting the money that we're currently spending inappropriately in hospitals to be governed and overseen by a structure in the community. So the what of it is that we propose under the neighbourhood approach to create 17 integrated neighbourhood teams. These will represent the sort of big 5 areas, but with stakeholders connected in. So that would be the trust community services, and indeed some of the trust secondary services that we believe should be community focused. The general practitioners, the community pharmacists, the voluntary sector and local government as the big players, but they would also have the ability, for example, to connect to independent care providers so that we can connect that whole wide range of services. And the essence is, and I want to make this clear right from the word go, these are not committees. What we've had in the past is structures that were kind of committees. This is almost like a management board for the community resource. And we believe if you coordinated the resource we've currently got, and then increase the resource by moving some of our care, so our budgets from hospitals where we're inappropriately treating people in hospitals, under the direction of those integrated neighbourhood teams, and I'm sure we'll talk about it, we've indicated this idea of 2% per year for the next 3 years in terms of an aspirational shift that we want to make, and we can talk about that actually that will allow us to get the right people in the right place, but also it will manage demand for some of our more expensive resources. And we genuinely believe that people will get better outcomes. To give you a very, very concrete example of that, so it's not just conceptual, if you look at palliative care, we know that people would like, that people don't really want to be in hospital, but that's true of declining years, older years as well. People would prefer to be managed in their own homes. And we have a lot of people who are currently getting care in hospital settings. If they're not palliative, they're probably deconditioning at higher risk of hospital-acquired infection. And very often we're admitting people for conditions that had been previously managed, and that's taking up valuable hospital beds that could be freed up to allow people who want elective care, for example, to reduce the waiting times for care, which we also know is an issue. So the what of it is really to create these structures in each of our 17 areas and give them the ability to direct that resource to the best place. And that might be about bringing a service out of hospital. It might be commissioning general practice, putting more money into general practice to deliver an alternative. It might be supporting carers in communities who, if they had more support, could actually support family members to avoid losing independent living, for example. So that vehicle is that's really the integrated neighbourhood team that sits at the heart of the neighbourhood model. In terms of where we are with it, very quickly, we done a whole bunch of work, and Cathy and Gro will be happy, I know, to answer questions on the stakeholder engagement leading up to this point. But in effect, what we've said is that we don't want to start this in piecemeal. So everybody is now working to identify their integrated neighbourhood team. They're on the footprints of the GP Federation, so we know the geographies of those. We had our first development day last week with 100, I think it's around 140 people, including the representative bodies, BMA, CPNI, etc., and very much sort of, I think, questioning and the implementation, but not the direction of travel, asking us how we can deal with some of their issues as we go through. But we will have the next 2 development days by the end of Q1. And so at the end of June, I would very much hope that we will be able to see in each of those 17 areas the team responsible. We've given them older people's care as a priority for this year, because we think that's probably where people aren't getting the care that they really could have, and we believe a neighbourhood approach is really fitting for that. And so this is going live as we speak. It's in development, and I'd be very happy to come back later in the year and tell you some of the outcomes from the work they're doing. Final point, Chair, is that I'd like to say we were the great innovators and creators of this model. This is happening really pretty much everywhere. Most health systems are trying to do it. The difference is we believe that we can implement faster because we're a small place and we've got the leadership that we need. And so I'm very confident that we will be a trailblazer across the 4 nations in terms of the NHS, and probably ahead of others in terms of demonstrating this neighbourhood approach makes a difference to patient outcomes and indeed financial sustainability. So that's where we are.
Okay, thank you. That's been useful. And the why, the what and the how, I mean, I think we're probably all agreed on the why. The what, we probably have some information. The how, we're probably a wee bit less clear on it. In terms of the 2% funding from the trust, what is that? What is the total monetary value for that?
Well, we're just working out the baseline of that 2%. If you took all the resources that we have, it would be around 150 million. But obviously some of those are in tertiary care where you wouldn't expect to shift. Some of them goes into other budgets that we run. So our ambition in the short term is that would be around the 40 to 50 million. But over the 3 years, we've said that would be over 3 years. I'd be very confident that over that period of time, we will be able to show a shift of somewhere between 50 and 100 million pounds of shift over that period of time on an annual repeating basis. Okay. So,
and I mean, in terms of the shift of that money, I mean, how is the department going to ensure that it's actually kind of new services out in the community as opposed to a repackaging of services?
So we've said we'd like that to be auditable, as in commented on by the audit officer, what's moving. We are working as we speak on the definitions of what we would count as that shift. Obviously, if we develop palliative care away from hospitals, we'll be able to demonstrate that. Another example, I was in the Southern Trust talking to their cardiologists, and they believe that they should be a community-based service, as they are in other parts of the world, in reaching into beds, not a current hospital service outreaching to try and manage prevention so you become more proactive. So we would have, effectively, plans. What we've said, we are, Kathy and Gro have been working on some guidance around what this means in practice. And I'll say a bit more about why this needs to be managed carefully. But we are saying we will monitor the trust throughout the year on demonstrating that this shift has happened. So there'll be an ongoing monitoring process. We've held off at the moment asking the trusts to put together a plan, because if we did that, the risk would be that it would be the trust dictating to those other partners you need in the community about what services they're prepared to move. And what we really want is the INTs to put the plan forward about what they expect to be able to do. And then, and it's probably worth reminding yourselves that I'm also the Chief Executive of the HSC as well as the Permanent Secretary, which means that the accountability of the trusts comes up to me as well. So if we felt that we were getting recalcitrance or we weren't actually moving at some degree of pace, there is a performance route to bring that up. The reason why we've got to be careful about this is that ideally I'd be in a world where I had an £800 million surplus, so I'd be funding double running. Unfortunately, I have a deficit that I'm facing, so we're having to fix the engine whilst the car's running, and that money is currently employing people and is spent by the trusts. So we have to do it in a managed way, which includes consultation with staff and indeed the clinicians agreeing that that pathway is right for change. So that's why we haven't said it's an absolute target. We've said it's an ambition, but we will be monitoring against the 2% figure.
You said 800 million. I was going to quiz the minister next time, because 2 weeks ago in the chamber he said 670 million. Last week
I might be wrong.
He said 700 million.
He's an optimist.
And this week he said 800 million. So I mean, it's a budget that seems to be getting 30 million more in the debt. So but from a committee's point of view, it's difficult for us to scrutinise the budget if literally over 3 weeks it started at 670, 700, now it's at 800.
But I'll push that back at you in the sense that I don't have a budget at the moment. So
then why are you quoting figures?
So what's in or what's out? Because I have to plan. Because I have to plan for. So in our planning assumptions, when we looked at the funding that we need this year that we wouldn't have in the draft allocations that were consulted upon by the Minister of Finance, we can see we got non-recurrent support last year for last year's pay award that we have to make. We've got next year's pay award, or the year we're in is the pay award. We have real living wage and national. So there's a raft of things now. The reason why there's still a degree of flexibility is because if you look at our commitment on elective waiting times, I'm still waiting for clarification as whether that's ring-fenced in my allocation. Now that's around 80 million. So you can see one way or another that could be contributed to savings.
I wasn't being flippant about it,
I understand.
And we understand that the department, like all the other departments, are stretched financially, and we understand the importance that the executive and all of us put on health. But it's just from anybody listening to a point of view, whenever the minister is saying 1 week it's 670, the next week he says 700, and the following week he's saying 800, it's hard to take it seriously. So I'm just making that point.
No, I understand completely, Chair.
Okay, back to this point, because I mean the neighbourhood model. You know, we're talking about moving care closer to the home, and there's going to be a particular focus on older people, which again I'm not going to disagree with, because I think that's appropriate. But we square that with the fact that our home care service is currently under extreme pressure, and that pressure is growing, and the fact that it is under pressure is already putting our health system under strain, because I mean, you used the phrase about shifting the money currently that's been spent inappropriately in hospital to where it should be. So home care is a key example of that. So I mean, I'm just wondering how this is going to help the home care sector that is currently under extreme pressure, where, this week we're hearing that independent sectors may well pull out. There's a particular problem in rural areas where people currently aren't getting the care and attention that they need, and because of the cost of living crisis and all the other external factors, that's probably going to increase because fuel costs are going up. So, if you were a care provider or somebody working in that sector looking at this meeting and this discussion, how is this going to help what they are currently doing and the service that they are currently providing to our vulnerable population?
The immediate answer to that is that they would be beneficiaries of a move of resources from hospital to community focus in the way that we've not been doing before, because we've been increasing hospital spend over the course of the last 20, 30 years. The only time in NHS history that we spent more money out of hospital than in hospital as a percentage of new growth was 2002-2005. So this is a real shift in what we're trying to do here. And for a lot of people, it is the care factor, not just the biomedical health factor that they need. So I would anticipate that we'd be in a situation whereby we'd be looking at I'll give you a really good example of that. If I imagine the way that the neighbourhood model would work in the way that I would hope, the neighbourhood team will have a list of all those people currently in hospital awaiting discharge who are medically fit for discharge, and they would be actively on a daily basis pursuing care packages to support that. Now, that means that would be resource that would be drawn from not just community health services, but community care services and homes.
Care services will get additional. Are you saying that care services will get additional money, will be able to provide additional?
To the extent that they would get additional money, it would be if the neighbourhood team believed that was the right thing to do to get the better service outcomes that we want. That would be for their discretion. The thing with independent care homes is that there are other issues at stake in terms of things like costs of real living wage, which we're currently wrestling with, and you know that issue well. The one thing that I would say that we need to do, and this is more of a strategic point, is that a bit like the independent healthcare sector, we've always had a sort of slightly more spot purchased, non-strategic relationship with the sector. And when I've spoken to the independent care providers recently, one of the things that we said was we want a longer term strategic relationship that actually is a financially viable position, so that you're much less vulnerable in terms of market shift. So part of our policy is to work with the sector, hopefully when we can get over some of the immediate issues related to real living wage, around what does a strategic partnership look like where you're funding care properly. Because the truth is, Chair, if you don't fund the care element, you will drive further costs in your medical and mental health elements. So that's why that strategic relationship is what we would want to do. But it's challenging at the moment because we know the sector's under pressure, and we are trying to do our best. But I would absolutely believe that they will be beneficiaries of expenditure to support developing care close to home. It has to be the case. And a lot of that will be in the domiciliary space, not necessarily in the care home or residential or nursing home space. It'll be in the domiciliary space, which I think was the issue in the South about rural healthcare.
And you referenced or palliative care a couple of times, and we've got members from the independent hospices with us today, and we're covering that issue in the second. So I've kind of cautioned members not to, but the fact that it is important in this conversation about neighbourhood model as well, because the department have referenced that. So, if I could ask, what specific role do independent hospices have in the model in the neighbourhood model in terms of participation in the IMTs?
Again, I'll pass on to Cathy after I answer this, because I think in our call for evidence we had examples from the sectors you've told about, people working differently already in that sector. So, but the end of life care, as you know, most people would like, if we are wanting to die, that they would, if they have to, they would like to do that at home with family and friends around them. That's basically what most people tell us that they would want in those last times. To be able to provide that, we need to have people who are capable of supporting them to be in their homes, and failing that, in specialist services where they can be cared for if they're a particular disease. And I think this is a combination of community services, which many of the independent hospice providers already provide themselves. Very few of them are just the beds. A lot of them have the outreaching, as you know from your report. And what we would be doing is that we would be increasing their ability to offer a package of support for someone approaching the last day of their life, which has a blend of support on a residential respite care sometimes, support for individuals who need that residential support, and particularly community palliative care. When we were in the Republic of Ireland recently, the numbers of people who the independent provider was treating in residential facilities versus community settings, I think it was about 20 out of the 590 that were in residential. The other was community. The good news on palliative care, and I don't want to spoil anyone's thunder later on, is that we have this active conversation now with Macmillan, and they're prepared to put a social fund into place in Northern Ireland. That could be worth around 10 to 12 million pounds, and that would allow us to actually double run a little the development of the service to avoid the hospital admission for people in their end of life. So this is an area where we're very confident we can show progress quickly in the neighbourhood model. And I don't know, Cathy, whether you want to, we do have examples of working well with the
Before
sector.
Cathy comes in, because if she could also answer, still I'm a wee bit unclear how, for example, any sector, but in this case, independent hospices will access any of this 2%. And I mean, the other key component of this is ensuring that there's equitable service right across the north, so that we're not having different things, or depending on where you live and you're getting a better service. So I mean, Cathy, if you can address those issues as well.
So I mean, the approach that we're taking in terms of funding for neighbourhood is, like I said, is a mixed funding model because of the position that we're in at the moment. So we have some funding that we are going to ring fence for to support the integrated neighbourhood teams, to let them get up and running. That'll have to be prioritised from within existing budgets. There's the 2%. That's really significant. That's sending a really strong message that we are really serious about change, and this is the beginning of long-term change. And that change, and we will be really considered in what areas we want to see that change, as Mike has expressed. But we are also aware that we want to use other opportunities like Invest to Save, and we want to use opportunities like working with those external partners as well. And we're really delighted with the approach that we had from Macmillan early on in our development of the neighbourhood work, because they are supporting neighbourhood approaches across the UK, and we're keen to do it here. And what we want to use that money really wisely, because we want it to inform long-term change rather than a short-term project, and work together on that. And that's really about care pathway design. I think you'll probably hear more of that in the next session around palliative care, and really thinking, because because those care pathways are often across the whole system. And I was involved and led the big discussion work on palliative care last year, and it was really apparent to me, without a whole system thinking around this, we're just not going to see the change. And there are excellent areas of practice already. So we're really keen to use the opportunity with Macmillan, because that's a substantial amount of money, to really think about plugging the gaps in our pathway and see what impact that could have. And there is an important role for hospices in that, Sarah.
Okay, I will pick that up obviously in the next session. I'm going to move around. Diane?
Yes, thank you, Chair. I'm going to preface what I have to say by saying I think this is a great idea. I want it to work, and I think it must work. But I also want to say that I have spoken to many people, GPs, people who work across the community, in all kinds of sectors, and I know we have representatives in the palliative care teams across Northern Ireland with us today as well. And they lack information, and they lack direction, and they lack guidance. And I think until we all get that and we all see that, I think that we're all going to still talk in a bit of a vacuum. For this to work, and I mean, you can correct me if I'm wrong. I would be happy to be wrong. The GP contract will have to be settled. We will have to have an adequate number of care packages in the community. Again, this bothers me significantly. Southern Trust is my local trust. I live 20 minutes from Craigavon Hospital. And, you know, we have 800 odd care packages outstanding. And across Northern Ireland on the 6th of May, and I checked the numbers for the 6th of May, we had over 600 people in hospital who couldn't leave hospital because they had no adequate care in the community. And so we're not just not helping people to stay in the community, we're not getting people out of hospital either. And until we address these significant issues, and until there's some sort of resolution to those and clearer guidance, I'm unclear as to how it will all work. And maybe I'm just being a bit dense, but I've spoken to so many people who say the same thing. I think we collectively all can't be unclear. So that's my rant over. So, but I would like you to address that. I think that people deserve to know how it's going to work. And, you know, if for example, you're on an end of life, if you're in palliative care, will there be somebody to help you in your last days? Will you be able to access that help, no matter where you live in Northern Ireland? Because I think that that's one of the biggest issues we have, given that we have 5 trusts serving a very small population, and it's that variation in service that's a huge problem. So I think we all deserve to know that, and I'm desperate for it to work, because sense tells me that moving people out of expensive hospital beds is the right thing to do. But if we're not going to, and I've said this so many times in the chamber, if we're not going to create capacity within the community, then we can't do it. We can't free up EDs, and we will still have the Royal College of Medicine coming to this committee and telling us that in 2025 there were over 1,000 excess deaths, and they put that down to long waits over 12 hours in EDs. That is a catastrophic situation for our health service. Yeah. So that's number one. So number two is really just a little bit more around the budget. So I've spoken to a number of trusts. So you're saying that 2% has to be moved for community care. Now I fear, I might be old and cynical, but I fear that many trusts already could account for 2% in the community care that they offer. So if you actually think, for example, again, think of the Southern Trust, which has a very, very excellent acute care at home service, and has expanded that acute care at home service when other trusts didn't. That you know, they could say that easily is part of their 2%. So I want to know, is the 2% new things that people are going to do, or is it existing things? And I think that is really, really important, because unless we are firm about the shift from secondary to primary care, we can't have this model. It won't work. We'll all hear next year talking about it again. You know, so that's not. And I suppose the third thing initially that I wanted to address is, I was looking in England about the rollout of care hubs, healthcare hubs. And, you know, all politics is local. And I was thinking just of Banbridge. Now, I live in Banbridge, so transparency and all that. We have an excellent healthcare hub, which could be one of those brilliant models where so much is taken out of the hospital and actually put into that local healthcare hub. It's where, on the site of where the old Banbridge Hospital, which is closed many years, but it's actually a brand new facility, brilliant facility, could be one of those healthcare hubs. But sometimes people are sent to it for an x-ray, there's no one there, because they've all been called back to Craigavon because of a staffing shortage, or they've been sent to Daisy Hill, or they're called for something else and there's no one there. Now, there's lots of brilliant diagnostics and so on carried out there and so on, but it just seems that we need to sort out that staffing issue in order to make those places really, really, really work. You can imagine how much easier it would be if a child had fallen and had their wrist x-rayed in Banbridge and was told, no, you don't need to sit for 4 hours or 6 hours in Craigavon. You know, you're okay. But that kind of immediacy is really difficult to get to. Sorry, I don't really want to be negative. I don't genuinely want to be negative because I think it is the right trajectory. But I'm worried that there are so many things that have to fall into place, particularly around GPs, around domiciliary care, and if we can get some of those right, I mean, if we could get domiciliary care worked out, we would free up our hospitals to tackle some of the waiting lists.
Yeah. So first of all, I didn't see that as negative at all. I think they're exactly the right questions, and we asked them of ourselves, in a sense of why would this be different to, because Northern Ireland's tried to do this. And one of the challenges that we get is, well, why is this any different to LCGs, or why is it any different to AIPBs and all the rest of it? And the truth is that we talked about this for a long time in Northern Ireland. Ben Goa talked about it, Transforming Your Care talked about it, but it was never executed properly. And sadly, at the time when that could have been executed properly, there was money to invest in new services. Yes. At the moment, under our jurisdiction, if you like, trying to execute, there isn't new money. We're having to try and save money. I think we could be defeated that, or we could say, right, this is the opportunity, we've now got to do something because you can't carry on. The rubber has hit the fan. Sorry, road. Mixing my metaphors. Just taking your challenge there, Diane, the only way that you stop the emergency problem that we have and people waiting for care, both elective and urgent, is you have to have the community alternatives. And the only way that we can create those community alternatives is by moving our current spend from where it is now into community settings. And we have to do that at a pace that's manageable because that's currently in the baseline of those trusts. So if we just took 2% off them, they would overspend by 2%, which is, so we have to shift the services and do exactly what you said, which is bring facilities into more local arrangements and make sure that our general practitioners and our, in the south it was the cardiologists who were saying we'd like to be based in the community so that we can see people in community and we all in reach to beds. So we've got to do this, but it's much, much harder because we can't double run. Now, why am I confident that you can do it? It's because when you look at reports like the Nuffield did in 2022, they looked at excess bed days and they said, how many people are staying longer than they should in hospital? How many beds do we have in escalation that really aren't part of the substantial establishment of the hospital, but they were put up to help manage winter, but they never go down? How many people are waiting to come out? What length of stay have we got that is in excess of what they would need to get the right treatment? And there's around £410 million in that 2022 survey that they did, that they suggested. If only what we did, and the English health system is not superior to ours, by the way, but if only what you did of what's happening in England around this, you could release around 410. The trick is, how do you get enough scale to be able to say, we will take that block of funding away from what we currently provide in a hospital setting, and that will be available in a community setting. So this idea of, I describe it as fixing the engine whilst the car's running, but we know that people are inappropriately being admitted to hospital. We know that people are staying longer in hospital that should have been home, and we have to release those. So we've got to be tougher on decisions about, I'm sorry, hospital is not the right place for you. And we have to be bold and courageous around the speed at which we try to move the diagnostic service, the elective service, the outpatients appointments. We do far too many outpatient appointments that could be done close to people's homes. So we have to work with our clinicians, and we need our clinicians on side. And on that basis, by the way, we are now in a new discussion with GPs about a new GP contract. Mm-hmm. And that's because the current contract does not incentivise the GPs, I think, to do what we want them to do. So we're going to have to find ways of moving that money around, and ideally being able to find some investment money that we can give them to sort of take on this. But some of these services don't rely on the GPs. If we could, looking at Cathy's area in a professional capacity, community pharmacy can do an awful lot more than they're doing now, and that would free up GP access. and that would allow the GPs again to do more work around frailty. And so, you know, you are in a way you've articulated the conundrum, but this 2% shift matters because it's the only time we've actually put a financial strategy underneath this commitment to move care.
But is it going to be 2% of
It's
new
extra.
additional money
It's
over
extra.
and above the services that are already
so
provided?
what we're looking for, this will not be new money. So this is money the trusts are spending now.
No,
But if we take your
shift.
example, if you take your level of hospital at home, what we would count towards our 2% would not be what exists now, because that's already funded. We would be saying, if you expand the number of beds that you have in your hospital at home service, that's what we would be counting towards the 2%.
And will there be an auditing process and accountability with the trusts that to make sure that that 2% is as you described?
Yeah, so what we've said is, and we've used the word auditable, so what we would be doing is, as soon as we get our integrated neighbourhood teams in place to put their plan forward for how that 2% would be spent this year, you know, we would be in a position whereby we will be holding them to account for delivering that. And we can get fixated with the 2%. The 2% matters because it's a concrete figure to aim for. I'd love it to be more, because I do believe that Northern Ireland would improve the value of its health service and every pound it spends if more of it was spent in a community setting than a hospital setting.
Just to end on that 2%. So if I was running the local hospice, how would I bid in for that 2%?
So what I would expect...
How would I access that? How do I get to that 2%? Because trusts and trust boards may well make the decision, well, these are the services we're going to do. How do I do that? How do I provide more community care, more palliative community care in the community, but run by the hospice, which seems a sensible thing to me.
Yeah, so I would expect that the integrated neighbourhood team has got a conversation, particularly given that we're asking them to focus on older people's care and end-of-life care is a big chunk of that. I would expect the integrated neighbourhood team to be in conversation with palliative care providers in the independent sector, as well as some of their own community services, about what more could we do to expand the opportunity to keep more people at home in their last days of life than we're currently doing, and what does that look like? Now, if that's a bid for a building, that's going to be very difficult because the capital wouldn't allow that. But can we expand the service by bringing people who are currently working in the hospital, or transferring some of the money that we're spending on vacancies that we're to manage in our hospital budget, and allow that to be released to pay for more of your care, to expand your community services? That's the dialogue that we would expect to be happening in each of those neighbourhoods. Not every neighbourhood will be the same. I mean, it comes back to the challenge about standardisation. If you're a neighbourhood in the middle of Belfast, you're probably looking at different levels of need and services as if you're in a rural area. And we know that some of the care issues are most challenging in rural areas at the moment. So there will be a degree of variability, but what isn't at odds is, one, the 2% shift that we want to see, and secondly, the priority being older people. So that's what we are effectively setting the neighbourhoods up to do in this first year. And you know, this is a policy, I think Cathy said this is for the longer term change. This is a policy that can run and should run for many, many years, because the reason why Northern Ireland spends as much as it does in England and more in Scotland and Wales and gets poorer outcomes for health is that we're spending our money in the wrong place. So this shift is a way of really getting the right people in the right place at the right time, which we always say is our real goal. And the 2% is a way of putting in place a financial flow change, not just saying that we want to do it. We are going to try and make sure that those resources, those service changes are spent and we can account for them financially.
We just need to move on, so I want to keep this fairly focused in terms of questions and answers, bringing on Danny. But just one point before I bring Danny on. 17 INTs, if we're talking 40-50 million in year one, you're really only talking 2 to 3 million each across those INTs.
Yeah, at first, yeah.
Okay, Danny.
Thank you, Chair. And like other members, I want this to work. You know, I absolutely agree with the direction of travel. You know, Bengo said it in 2016. We need to move our services into the community, and we haven't been able to do since. So, you know, certainly this is the right thing to do. I'm as yet unclear as to how it's going to work, so I was looking forward to today to hearing a bit more about that. I know we've had a presentation a couple of weeks ago, because we're in crisis at the minute, you know, and I'm hearing constantly from people who are working in healthcare about the level of pressure within our hospitals. We're in May, you know, we're not in December or January anymore. We had a briefing on Friday about 45 patients who were medically fit, sitting in an A&E in Antrim Hospital with 115 medically fit patients in the hospital that couldn't be discharged. So those patients were being looked after within the unit, unable to go to a ward. And on the wards, I'm hearing from nurses that the level of pressure they're under with corridor care is increasing significantly. Patients with, you know, quite serious conditions are being treated in corridors with no dignity, and that's increasing. That's putting extra stress on the staff as well. So we are in crisis here, and I understand that 45 patients had increased to 70-ish on Tuesday morning over the bank holiday weekend, because obviously very few discharges over the bank holiday weekend. So we are in crisis. We need this to work, and the bottleneck is clearly at the back door. And unless we build capacity in the communities for care packages and for nursing home placements, you know, we are not going to move that pressure. My question is, the first question is, do you know how much we actually need? Do you know the numbers of care packages and nursing home placements that we need at the minute and that we are going to need in 5, 10, 15 years? Because we know that the number of over 60s and over 85-year-olds is going to significantly increase by 2040. I think the number of 85-year-olds in particular is going to double by 2040. And we don't have the capacity in our communities at the minute.
I mean, look, I don't have it with me today, but SPPG do, and it's monitored, and we look at that. And for those trusts that are in difficulty, there are support services to help them, as we did at the bank holiday after the New Year. Bank holidays are a particular difficult time, as you know. I mean, this might sound counterintuitive, and I want the committee to think hard about what I'm about to say, but for hospital staff who are under significant pressure, they're actually under pressure because they're dealing with people who, if we had the community services in place, would not necessarily need to be in there, right? So the only way that you can address that is by finding a way to take money away from the hospital to spend in a community setting. Okay. Now that might seem, you know, because the answer when you press for a bed, or I'm saying, can we take down the escalation beds and reinvest that in a community offer? And it works on the basis that if you can create the community service, you will affect more than a multiple of one patient. So that community services affects many people, and that individual, therefore, that means that we can start to take capacity out of hospital. Now, this you know, we know the ageing population is growing. You know, and I should declare my conflict of interest. I am over 65. I know it surprised you, but I am. This is a problem that if we don't fix it now will only get worse, because we know more people need care later on in life. But when you take a decision to admit someone into a hospital, we know the benefits, i.e. you're close at hand and you'll get medical treatment, but a lot of that treatment can be provided in community settings. What happens is that you risk deconditioning whilst you're waiting in a bed, you're at greater risk of hospital-acquired infection, and frankly, you're probably not going to come out with greater outcomes. And so we need to explain to the public around this policy that this is going to help them by effectively reducing hospital capacity in the short term to enable us to provide a better community service.
And that's exactly what I want to see. I want to see that work. I'm not sure how it's going to work. So my next question is about the INTs. So we have neighbourhood teams based on the federation geography, the GP federations at the minute. You mentioned that older people's care is going to be a priority. So you're directing the INTs to have a priority, have a direction of older people's care, focusing on that. So you're giving them guidance and direction. Is that correct?
We've already done that. We set out in the publication that came out when, Cathy?
Yes, well, we have prioritised older people, and we have indicated what areas we would like to see the INTs to start with, but that is what we're getting into now in our workshops as well. So we've had a first workshop where we brought sort of everyone together to talk about, just to socialise the issue more widely, I suppose. But now in May and June we're getting into much more of the planning, like I think which is what you're pushing to put towards, you know, like what will this actually look like? You know, if you are an INT now and you're coming together, and we will help you to understand who your population are and how they're using your services currently. We're asking you to focus on older people. We'll define that. We'll have to define that. How many older people? Where do they live in your area? And what exactly would you like? You know, what exactly would you be focusing on this in the short term? We would like to see some short term work being able to start this year on this. I mean, to begin with, we will be asking those INTs when they come together, just think about the services you're already commissioned to provide and that you're already funded for. And what we know from experience of seeing other neighbourhood models is just getting people in the room and talking like that with purpose. A lot of those service providers will never have done that before. Even those who work really closely together, like our GPs and community pharmacists, they don't get an opportunity, let alone our social care providers and our GPs. And there can be small things, small changes that can be made that can really help. And to focus then on what we would like to really see, Danny, is like focus on 3 main areas for that population, helping people to stay well at home this winter. So that can be things like, you know, if for our older people, really a big focus on our vaccination programme, for example. Let's look at our data from last year, how many admissions to hospital we have for flu. Let's really focus on that. But also the proactive care models that Diane mentioned, and anticipatory prescribing, all of those things. Are we making the most use of things that we can already do, that we're already funded to do, and just being more sort of meaningful and working with purpose? Stay well at home. The next one is helping those older people and at-risk people at end of life as well to access the care they need in the neighbourhood, in those services. So we are going to have a focus on access as well. And again, by asking people to think, look, how can you work together to mean if someone needs care today, how can they get it in the neighbourhood? And then the third area is that how can those services as well start to work together for their own population and think, how can we get our people back home when they're medically fit? How can we work together? Because some of the barriers, it isn't always, we've touched on some of them here, but it can be there are other barriers in the system, small things, and there's a sort of accumulation of things that can happen. And so there are opportunities, I think, but it's starting somewhere. And that's why we're focusing on older people this winter and focusing on those 3 areas.
You mentioned end-of-life care there, and I know we are discussing palliative care later on today, and palliative care obviously is part of the neighbourhood model. They're delivering a lot of services in our community. Will palliative care providers be part of the INTs? Is that it?
So just last week with the group in terms of the first development day, we asked about how can you make sure that those organisations that have got a contribution to make aren't strung up in terms of having to find 17 people to sit around the management board each Monday morning around what's happening in our community, all the rest of it. And one of the options we debated, which we haven't landed on yet, so this is still in consideration, is a bit like when the primary care trusts in England had a professional executive committee, that there was a group of wider stakeholders who met and talked about the clinical changes that could be made. And I would imagine that in that scenario, we would have our hospices, our independent care providers, going back to the original question, our independent health care providers, not just our care providers, who are effectively involved. I think optometrists is another one who they can't support every single INT meeting, but they would have the ability to bring guidance out to support each of the 17. So that would be a way to make sure that our end-of-life care providers are really able to inform the art of the possible, so that these INTs understand how they could transform palliative care. So
I would imagine they'd be very interested in being very involved in it, because the services they do deliver at community level. Were they at the development day? Were they invited?
I'm not sure, I don't think.
I don't think the hospices specifically were. The hospice, I mean, there was a focus on kind of trust and community services as well as general practice, community pharmacy. I mean, it was we cast as wide in it as we could for that initial workshop, but the next iteration
wasn't very wide if you didn't invite.
No. I think that's a we'll apologise for that, because I think there was no reason why we couldn't have had them there, but we will catch them up.
Yeah. Will you commit to inviting them to future ones?
Yes, of course.
Yeah. Certainly, you know, as we've spoken about, they're obviously a key part of this neighbourhood model, and certainly I think they should be.
And as you're aware, I gave up a day of my time to look at interesting models of palliative care very recently. So
That's my next question.
That's certainly something that, you know, end-of-life care, when you look at that as a proportion of the spend on older people's care, is a significant proportion. It's a brilliant piece of research, not published yet, so I won't say too much about it, but it was also at the university, funded by Marie Curie, around how much the end-of-life, your last year of life care costs are. And it goes on to describe the total costs, but within that you can see real opportunities if we were working with our colleagues kindly to provide alternatives for saving some of that money and getting better patient outcomes, which is the critical thing.
I know you did visit St Francis's yesterday with myself and the chair in Dublin, and we talked about their journey, a long journey of 20 years to be able to get to 100% funded palliative care service, which was a fantastic achievement down south. And I just wanted to ask you just about what you took away from that. What was your learning from that yesterday?
So I mean, I took away a slight disappointment in the sense of I'd rather hope that their business case for change gave us more insights into the value proposition of cost of care in palliative and community settings versus what was being provided previously. But as you know, they were able to increase funding for palliative care when they were getting overall growth in their budgets. We don't have that, and so we have to argue about where you would take resources to spend them in palliative care. So that was slightly disappointing, but on the other hand, they have a lot of, I think, evidence, and when I was walking around I was talking about it afterwards, of impact of where their community service model is having a big impact now and what's that happening. And I think their research and evaluation capability, it would be quite interesting to ask them to look at our model that we're trying to develop and evaluate that. And I know at the moment there's a bit of this conversation this afternoon about chicken and egg, how will we understand it and what's going to change. I think as we go through, we will learn by doing, and I'll be able to come back to you and say, and I think that's when you'll start to see. And the reason I'm very confident of that is because when you look in other places, this is already happening. And I know the committee is going to come with me on a visit to London, and we're looking at 4 things. And you'll get a real sense of what we would like to do from those things in Northern Ireland. Now, obviously, it'll be the Northern Ireland version of that, but it gives you a lot of confidence that you can target those people at risk and you can avoid the hospital admission and deal with inequalities as well, which is one of the presentations we'll get. So I'm confident that if we can get everybody to believe and trust us, and it is fair to say that quite a number of people have said, well, haven't we done this before? But I don't think we've done it with the discipline and the rigour and the thoughtfulness and the determination that we've got this time. So I think hopefully when I'm back at this committee, as I'd love to be in the autumn telling you about the progress that the INTs have made, you'll be able to see that we were talking not conceptually but practically about what we expect to happen.
Alan Robinson.
Thanks, Chair. Thank you, Permanent Secretary. Like others, I don't think there is anybody within the community who don't recognise that they want to see improved and better services. And if this is the direction of travel that we need to go, then certainly we're up for it. We're always up for that challenge. And I'm sure the public will support that challenge too. I just want to ask, there's a number of questions here, but I want to just pick up on a comment that you said earlier. You said about England doesn't have a better healthcare system than ours, but if they are already administering this model, why are they not the very best then, if they have a similar model? Surely that's not an admission of fear already.
So I think my first comment was England doesn't have a better health system than us overall, was a more general comment about I don't think you can look at England and say everything in England's perfect, we should adopt everything. So that was a general comment. The other thing is, if you look at England's approach to neighbourhood, and they've just issued their guidance, they've been at this for 3 years. When you look at their model, it is there, but it's very patchy. And what we're trying to do, for all the reasons that the Chair challenges on, is say this is for the whole of Northern Ireland. So I can take you to parts of England where I would say that illustrates exactly what we would want to do. However, that's covering one primary care network area, which is 50,000, and we've got so that's where I think we can learn from. But I don't think their implementation of this policy is ahead of us. And it's more complicated for them than it is for us, because they've got 3 different models of neighbourhoods, where we've got a fairly simple structure of neighbourhood. They're talking about 3 different models.
Okay. So if you had a crystal ball for June of 27, what would be the specific outcomes that you would like to see from June, whenever this management board should be in place?
Yeah, so June 26 or June 27?
27.
Oh, well,
next
that's a year ahead.
year.
We're hoping that these management boards, these INTs, will be in place in this year, and we'll have done the first 3 days of development by the end of the quarter. So I think you'll be able to see them in place. The impact that I think they would have would be that they are in a position to help Northern Ireland by looking at more areas of just older people's care, about where redesign of services is possible, and we'll start to see some examples of where what you would otherwise have been in hospital for, or waiting in a hospital for, is direct access through community services. So you would effectively have people who are being cared for in the community who this time today would have been admitted to a hospital.
Okay. Will there be any digital systems be required to support integrating this model?
There are, but in essence, because the EPIC platform talks to EMIS, which is the GP platform, we think it's a question of asking our systems to deliver it rather than investing in new ones. But what I'm really hopeful, and I'm going to show the committee this in June, there are systems like Eclipse, which is the one we're going to look at, which has a record of your entire population. And it starts to predict need and deterioration of people depending on the information it's got. And where it's been used in England in parts, this is really helping people target the information on their attention on those people at greatest risk of hospitalisation. And of course the data's all there, because we know the number of people with chronic disease, their hospital admission over a period of time, and so you can start to use that data to target those people. So it's more of a software package to support our data platform, and certainly that's something that would be in our investor save category, because that's exactly what you would need to have. The other bit of decision making software is to help our resident doctors and our consultants understand that there is a community alternative in place, and so they don't admit by default, and they refer to that. And you can see that in decision-making tools. And I've asked Paul Rice, the CDIO, to look at some of the most effective ones of those. I've seen one called Interpreter, which is really good. But it's a decision-making tool that stops you admitting by default, and you have to override it if there's no alternative. Because what we do find is that resident doctors, I was looking at the resident doctors will admit by default if they don't know there's an alternative, because they don't want to send someone home who looks like they need care. But that perpetuates that admission of people who could have been care elsewhere. So the decision-making software allows you to sort of say, been through the process, hospital admission is not required, and then you have to override it to make an admission. So it helps the resident doctor, particularly resident doctors, say, I'm going to refer you back to your GP. This is the support line that can help you. These are the community services, someone will be in touch. So it stops that admission by default, which is our kind of position that happens now, and it starts being, I don't need to admit you. That's another piece of software. So that and Eclipse are 2 areas that we're going to look at to help the neighbourhood teams do their jobs.
Appreciate it, Mike. We certainly look forward to the further update in June.
Thanks. Paul?
Thank you, Chair, and apologies for missing the start of the meeting. It was at the policing board getting on the road. And Mike, I genuinely going to try not to be cynical, and I'm 6 years in the health committee and it's near bait into me at this stage to be cynical, so I'm trying not to be, because I think we are genuinely desperate for something different and something new and something that will try and tackle the issues. But I have just one issue that you might be able to explain to me that would help me in this model, and it's this. If we shift 2% of our funding out of basically hospitals and into the community, with the idea being that we deal with people in the community and not the hospital, we're still dealing with the same number of people. So how do we deal with the backlog, which is what we would get mostly in the neck? Now, I'm going to hope what you're going to say is that for the cost of what you spend on people in the community, you can deal with more than you would in a hospital. But the problem is that we are having an ageing population. The projections are that as we progress on, there's going to be more and more people that are going to need services. And if we're essentially just shifting from one side of the house to the other, how does that capture more people and deal with backlogs for us then?
So there's evidence that providing that service is providing it cheaper because you get to people earlier and you avoid excess costs and wasted resource. And I feel bad saying wasted resource is someone waiting to come home. That's a person, but actually there's better ways that we could use the money and help them as well. So you would get a multiple benefit because you would be providing a service rather than the attention on one individual in one bed. I think the thing that I would also say, because we focus a lot on the 2%, the 2% is really important because it brings new resource, but we've also already bringing in new resource to the community through things like the Macmillan support. AstraZeneca are supporting us through that, recently signed on respiratory, and we think we'll get some money through our Innovate money around dealing with obesity. So there's some new money coming in. And we also have transformation funding, as you're aware. Our bids on electronic prescribing, dealing with transitions for young people, all of that will be played out ultimately when it's all in our budget across to by the neighbourhood. So with that, but I'll come back to Kathy's point that she started with, which is that we're already spending a lot of money. It's not too, I don't know whether you were indicating, Dan, that you thought it was 2% in community. We're probably spending about 30 to 40% of our total budget in community already compared to the hospital. So there's a lot of money we can spend better by coordinating services. And that idea of a management board for the community resource is that they will look at where are we spending our money now, what are our problems, here's our list of 30 people by name who we're trying to get back out of the hospital, what are the packages of care we should put in place for them. So it's a very practical model, and it's looking at, we already have community nursing, we already have general practice doing things, we have advanced nurse practitioners, we have voluntary sector. So you would be literally coordinating the care, and I think you get added value for that. So that's probably 4 areas where you would get that added value of what we're trying to do, and the shift of the resource is one of them, but the others are significant as well. And we have, last point, we have lots of evidence in the when we ask people to come forward in the call for evidence of things that are already doing, but they're just not at scale, and we could and should do them wider.
And is there an assurance there that if you move services in, because I don't want to fixate on the 2% either, but if you move services from hospitals out into the community, then, like, number one, will those trusts be subjected to further cuts? Because I think they've had not just cuts, but they've had obliterations in the last number of years where they've been asked to find 50, 60, 70 million pounds worth of cuts, which is quite substantial. And if they're trying to shift services out the door and deal with a diminished budget, that's going to become increasingly difficult for those trust CEOs to find what to actually do differently. And then if there are savings, is there a way that some of that saving can be delivered back to those trusts in order to deal with the flow through the hospital that we need to see to try and help patients that are in EDs?
Yeah, it's hard to have everything.
It's a short list.
So first of all, we are asking the trust to make efficiencies because we have to, because our budget does not cover even last year's pay award, let alone next year's pay award sort of thing. So we have to make efficiencies, and the figure we've got at the moment is 6% that we're looking for. Over the 3-year period, we're hoping for a profile of 633, and by the end of that, we should be in run rate balance if all goes well. Now, that requires some support from the executive over and above our allocation, which is why this is very difficult as the accounting officer to get to a position whereby I can look at balancing the budgets without asking for significant reductions and savings. But more of that as, you know, as things get crystallised. I think the point we're making is that the way that you save your 6% without making service reduction is by investing your 2%. That's the kind of approach that we're taking, because if you can avoid the admission, you can then reduce your need for staff. If you can get enough of it, then you can reduce your need for staff, and that plays into our vacancies and our costs of premium labour costs, because we're filling some of our vacancies with additional staff to make sure that we can cover who is in hospital at the moment. So this is why this 2%, it starts the process of enabling the trust to right-size their financial position, not just their service offer. And without the 2%, it would be incredibly hard, I think, for the trust to start making those efficiencies. But we have beds that are currently up as escalation beds that really they go beyond the establishment that they were commissioned for, and we need to. They're being paid for by the trusts, and we need to move those people away from our hospital to allow them to then release the costs. What you do with the costs is a political decision. The costs you save. So in England, and I can demonstrate, after the QOF was introduced in 2002, general practice, you saw a major dip of about 10% of ambulatory sensitive conditions going to hospital. That created capacity in the hospitals, but the government at the time said our priority is to use that capacity to reduce elective waiting times, and they put a profitable tariff against any episode that you did, and all of a sudden that's where that cost went to, and that capacity was used. But it did get waiting times down from 18 months in 2001 to 18 weeks by 2008. So it's a choice. If Northern Ireland is faced with a fiscal challenge, it may choose to say we need to take that money out, as opposed to say we'll use that. And we're still waiting for confirmation of this, but at the same time as we're doing this, we are still racing ahead with Programme for Government, which is really about trying to reduce the elective waiting time. So we haven't forgotten about that. But if you really want to get waiting time down permanently, you've got to deal with the stock of people, which is what we're doing with the Programme for Government, and the flow of new people. Because if you just operate on the stock and you do nothing about your flow, your number will go up. So that's where the neighbourhood is about flow management. The stock is the Programme for Government.
The cynic in me would have said, were you going to invest your 2% on red, black or the horses? But I know I'm not being cynic today, so I'm going to say hopefully it'll get it all sorted. Hopefully it'll get it sorted, but we'll wait and see.
Okay. That's us. Thank you very much. Appreciate you coming before us and giving your time. Just before we do allow you to go, so thank you for the visit yesterday to St Francis Hospice. That was very valuable, I think, in the work that this committee is doing. Hopefully you found it valuable. Also, thanks for your help in assisting with the visit to London as well. I mean, we talk a lot here, as we have been today, about changing policies and shifts within our health service, which we all recognise we need to do and which we hope for success. We're conscious that a lot of these decisions, the current minister has indicated he's not going to be here in the next mandate. So, and maybe unfairly asking you about your own position, because, I mean, we want to see, you know, kind of leadership driving some of these changes that we recognise we need it. So, I mean, I don't know if you have any view on your own future.
As a matter of public record, this is a bit tricky. So what I can tell you is that the facts are that I'm contractually agreed that I will be here for the first 6 months of this year. That's out to September, and we're in discussions about that extending further to the end of the year. I think there is a question which I would say that the Health Committee should be interested in, about when you get beyond the next election, having someone who might be able to do 5 years. So that continuity, I'd be very concerned if I felt that what we weren't doing was embedding a direction of travel and someone came in and took it in a different direction, because I think the service is really behind this, and I think people understand the logic of it, and we've done a lot on the culture and the style, and we feel more like one team, and you know, the trusts now are with us. We don't have an us and them perhaps in the same way we might have had in previous years. So I think there's, I think from my perspective, I'm here for definitely till September, and probably to the next election, and then obviously it's a question.
And that was a very unfair question to me, but I asked it for that specific reason, because I do think we need we do need some stability, and we need a continuation of leadership. Obviously, we're not going to get that from ministerial position.
You
but
should
I think
probably ask my colleagues whether they'd like that to be the case.
Yeah. Okay. So thank you very much for your time. Thank you.
Thank you.
Okay, members, we're going to have to. I don't know. I've never done this before. Does Gerard have to go out to come back?
I don't mind.
So members, just moving on then to item number 6, which is the oral briefing from the department, access to palliative care. So can I refer members to page 32, and can I welcome Mr. Jim Wilkinson, Deputy Secretary, Healthcare and Policy Group. And Gerard, who has stayed with us, who's the Director of Primary Care. Can I also welcome Mr. Roger Kennedy, Programme Director of Community Care Directorate, and Mr. Ryan Wilson, who's the Director of Secondary Care. So thank you very much for your attendance. We have, you have read a report. We have got your response. I don't know if you want to make any kind of opening remarks before we get
Chair,
straight to
just
questions.
make a few short opening remarks. I think the context in terms of the earlier discussion probably sets a lot of what we want to talk about. But first of all, thank members for the opportunity to attend today to discuss the department's response. I said I'm Jim Wilkinson, Head of Healthcare Policy in the department, and that policy remit includes both adult and children's palliative care and advanced care planning, and a number of the areas that are covered within the report. As you've advised with me today, I've got Gerard, who has the joy of being here on a repeat basis. He's been here for the first session. I've got Roger Kennedy, who's the Programme Director in SPVG with responsibility for palliative care, and Ryan Wilson, who's the Director of Secondary Care, which includes responsibility for children's pediatric palliative care. I know they've both, all of them have been here at briefing the committee as it was part of its evidence sessions. Following on from the previous session, the Neighbourhood model of health and wellbeing, I know members will be aware, is both a key strategic programme for the department, but also, we believe, critical to supporting and improving palliative care. And a point I'm sure I'll return to, but will also return to as part of these discussions. The timing of today's evidence session is very appropriate, as members will no doubt be aware this week is Dying Matters Week, part of a campaign by Hospice UK, which aims to encourage openness in talking about death, dying and bereavement, and which this year is focusing on the importance of conversations about death and dying. A number of events are being held here, including death positive libraries supported by compassionate communities, local trusts and libraries NI. The department recognises how important palliative care is and the difference it can make to people living with life-limiting conditions, as well as the support and reassurance it offers to families and carers. So too does the committee, and the Minister has recognised the breadth of the committee's inquiry and has welcomed its report. The report sets out an extensive and challenging body of evidence provided by, amongst others, palliative care providers and those with personal experience of palliative care, including carers. The committee has made 27 recommendations, a number of which include several elements. Together, these recommendations cover a wide range of areas. The department has accepted in full 19 of the report's recommendations and partially accepted others, and no doubt we'll get into some of the discussion on that. Our intention is now to move to implementation of the commitments, and we've made a response to the committee's report. And I think that's one of the things I want to stress. I think importance is implementation and discussion. We've got the evidence, and I think giving some assurance around governance will be important. Whilst we make every effort to deliver on these, as we've noted in our response, the department faces challenging financial circumstances and pressures. In light of these, we may need extra time, because I think a lot of the discussion has quite rightly been about how we prioritise and direct existing resources rather than how we apply new resources. As I've referenced earlier, and as you've seen from the department's response, we believe implementation of the new neighbourhood system of care has the potential to make significant difference on palliative care services for Northern Ireland, enabling more people to be cared for in the place they call home and in the community. As a model that also focuses on prevention, the aim will be to identify earlier those who would benefit from palliative care in order to ensure timely intervention and to prevent, as far as possible, inappropriate attendance at hospital and EDs, especially for some of those at the end of life whose wishes to remain in their home in their final days. As the committee heard earlier, the Department launched the policy framework for Neighbourhood model at the end of March. This is just the start of the journey to reform how, where and by whom services are delivered to best serve our local populations based upon their specific needs. The committee will know that a majority of palliative care is generalist palliative care, and the department acknowledges the important role of general practice and district nursing teams, as well as those working in care homes, domiciliary care and providing palliative and end-of-life care. The department also recognises the role of hospices in providing specialist, palliative and end-of-life care. I'm aware that over the course of the inquiry, the committee members visited our local hospices and saw at first hand the valuable work they do caring for, supporting people with palliative care needs, as well as those who are important to them. Over the past 4 months, I myself have visited each of the adult hospices. I've had the opportunity to speak to the hospice representatives about the services they provide and to hear their views and expectations from the committee's report. I also had the chance to hear and experience patients, families and carers, and I'm very grateful to those who spoke to me for sharing their stories. It is clear that hospice rightly hold a special place in our local communities. The department commends the expertise, professionalism and commitment of all those in the palliative care sector and the wider health and social care system who provide care and support for people living with life-limiting conditions. We also recognise the vital role the carers play in supporting family members and loved ones, often in challenging circumstances. As we seek to deliver on the commitments made in our response to the committee's recommendations, we look forward to working with palliative care providers, people who use palliative care services, families and carers, and other stakeholders to transform services. Thank you, and as I said, we're very happy to respond to questions and into more detail on our response.
Okay, thank you very much. So, I mean, there's a committee report, your response to that, so obviously it goes without saying that the committee views this issue extremely important. You said that you visited the hospice, so there'll be nothing you won't hear from me today that you haven't heard already. I mean, we're going to cover a lot of subjects today. I'm going to try and cover funding and resource, but it's important that at the back of all of this that we're considering outcomes, but clearly funding and resource is vitally important. So, I mean, there is this disparity about the value that the department puts on beds and the service provided within a hospice, and I mean there's no agreement with that. I mean, it's clear that from the information the department is supposedly paying 50%. There's a view that isn't the case, that the value of the benchmark the department is setting is £824, despite the fact that the beds cost in Antrim, which is within the remit of the department, costs £1,150. So there's immediately this disparity about whether hospices are even getting 50% fund, and it's our view that they're not getting that fund. And in our report we have actually said that we want to see the department move beyond 50% over a 5-year period to 100%. So in terms of the recommendations, the department are saying no to that. Am I correct in that?
The department, and I think you're right, and I'd be clear, every hospice I visited, one of the key challenges they faced was the sustainability of the acute beds, which are the ones that we're talking about. In terms of the department's response, what we have said in our response is we want to move collectively towards a sustainable funding model for hospices. Now, the question of whether that's 100%
so
funding
can I
or not.
ask, just in terms of moving that, because I'm going to come to this with regard to criticism, have you done a business case? I mean, what is a sustainable funding model? Do you know how much 100% cost of the service provided is? How much that would cost the department?
Well, I suppose there's, and I'll bring Roger in to talk a bit more detail. There are really two elements to it. The first element is trying to put some funding into the system as is on the basis of the information we've got. There's a second element which is looking in terms of a lot of our benchmarking exercise to try and reach that cost, because the costs vary across hospices as well as across systems. So there's work to be done on reaching what is that benchmark.
Where is this work?
I can ask Roger maybe come in and give some detail on the work that's being taken forward in terms of needs assessment and benchmarking.
You're saying there's work being done in terms of what resource has to be put in to the system, but in your response to us, you're telling us you're not putting any additional resource in.
There's two elements to it. One is additional funding that we're putting in on the basis of the current and existing model. The other is to look at what is a more sustainable model. And in looking at that sustainable model, we need to assess demand, we need to assess costs, and we need to come up with an agreed approach that makes sure it's sustainable. Because what we're all agreed on is that the palliative care and hospice system is a critical element of the palliative care system, one that we need to maintain, and it's a service that I think the committee found is an excellent service in terms of the quality and standards it provides. But Roger, do you maybe want to say a bit about the work we're doing and the work we are applying to?
Thanks. Chair, bring you up to speed on the benchmarking. So we did a benchmark review on the 50-50 funding that was paid in February this year, so it's fairly recent. And that included working with SPPG Finance, the new PLIX finance system, the patient level costing, and obviously Hospice Alliance colleagues. That resulted through that review of an additional payment of £600,000 being made across all hospices for 25-26, backdated to the 1st of April.
Was that additional payment based on?
And that's based on the current numerator at the moment, which is the gen bed.
All based on the fact that you are not recognising that you pay more for this Antrim system as opposed to the hospice system.
I think the Antrim, go on to the Antrim system, I'll pick up a bit of that. We did have a look at the costs in there. It is incredibly challenging to compare both services. Some of the costs within a wider trust environment are fully absorbed. They include direct, indirect costs. I'm not an accountant, but the cost comparison to compare, they are not standalone units, so they're cost based within Antrim site, for example. Very hard to extract those costs out to compare apples with apples.
I'm going to keep interrupting here because we've limited time and I want to get to the bottom of some of this. I mean, you recognise what hospices do is specialist care. Mm. So, I mean, even if you were comparing what hospices get compared to a hospital bed, so, I mean, I understand you might think there are difficulties doing that, but there are other methods that still show that hospices are currently getting less than what they should be for the specialist care that they're doing. I mean, and I don't want to boil this down to numbers because, as I say, in our view, what palliative care is a societal value to it. So, I mean, we were in Dublin yesterday. I mean, very clearly, that's what struck me when I came away. So, society puts a value on ensuring that people get the care and attention that they rightly deserve in their last days. So that they get to die where they want and how they want, with their family and loved ones around them, getting the care that they deserve. So, I mean, there has to be a societal value in that, and I think certainly what this committee has viewed, because the Minister continually asks us, when we asked him difficult questions, well, prioritise, tell us what your priorities are. So we have told him that this is a priority for us. So we want him to action this priority we have given him, because we want people, we think it's appropriate that people that this service is funded by the public purse as opposed to people having to fundraise to ensure that our loved ones get the kind of last days here that they deserve. So, I mean, I think it kind of shocks me that when we have done that and give the department a number of recommendations, that you're not able to come back here today, a number of months on, we give you additional time and say, well, here's how much it would cost this year, next year, the following year, over the 5 years, so that we could have a better conversation about that money. I mean, you're basically coming saying to us today, even after this period of time, we accept, because the Minister does this and he does it very well, so I agree with you, but I haven't got the money. Well, right back at you to the Minister today, will tell us how much money it actually is going to cost.
Yeah. Okay, I mean, I'll bring you on, but just to break that recommendation, I think there's three elements to it that we've been looking at. The first is the element Roger's described as how do we get some immediate money into the system, and the way we've done that is use the existing benchmark, and that has put the additional 600k in it. I think then there's the second argument is, have we got the right benchmark? And I think we've agreed that we do need to look and review again, working with the system, as what is the benchmark.
You're going to look at
that. But that needs to be looked at. I think it has to be looked at. What we're saying is the Antrim one is not necessarily the initial one that we could look at because there were different costs in it. And then the third element to it is, what is a sustainable funding model for the hospice? Is it the 100% funding recommended by the committee? Or is there an approach which recognises the independence of the hospice, recognises the value that is put in that independence and their fundraising, and looking at what is a sustainable bed cost? So those are the three elements of it. The first element is the 600k. The second element is reaching an agreement as what is the costing the beds we've got, and the third element is what is the progression that would take us towards making that a sustainable.
And the committee have done a lot of engagement, including with the hospices, and our recommendation is the 100%. And and we're not asking for something that doesn't happen elsewhere. We visited St Francis's twice. They have 100%, and they allow the independence of the hospices to do additionality through their fundraising and provide additional services. We're the same in Scotland and the same in Wales. So we're not asking for something out of the ordinary here. As I say, this is about putting a societal value on people's end of life care.
Well, I fully understand the committee's recommendation, but I might bring Gerwin in if you want to say something more about those.
And just, I guess, to build on what's been said already. We really welcome the report, and we welcome the focus that the committee has put onto this as an area. Your question to Roger about, is this a specialist service? I think you're getting about the comparator. Is it a specialist bed versus a general medical bed? That was reviewed, I think, most recently in 2019, but keep me right on that. And at that point, it was felt that a general bed was the appropriate comparator. Jim said we will look at that again, just to make sure that remains. But that's what was done. We will look at it again to see does it remain appropriate. I think it's important to say as well that a general medical bed will have some specialist input to it in the hospital costing space. It's not just exclusively as black and white as one or the other, but we will look at that. I think there's something too. In the previous session on neighbourhood and how will hospice specifically be involved in the INTs, and what is the role for how do hospices avail of or get involved in the 2% shift. I think that's and we covered off, how we can maybe make sure they are represented in the wider discussions on that. I think there's a point too on, the INTs will be looking at the patient need and where hospice is the most appropriate, where a bed in a hospice is the most appropriate. That's something definitely we'll need to see funding flow toward that. But the community-based models for palliative care are also really, really important and are underserved, and that can involve hospice providing those. It's not just a bed-based one, but I accept that it is a key area of focus for the committee. So.
And there's more to this than just the hospice and the acute or the acute. Are you saying, Gerd, that you don't think palliative care in a hospice is an acute service? Is that what I took from what you were saying there? No, I'm saying that the comparator that's used for the 50-50 model is with a general medical bed in a hospital. That's how we cost up what's funded in a hospice versus in a hospital. And there are, And when that was last reviewed, it was found that was felt to be still an appropriate comparator. I'm not making a judgment about the service. I'm just saying the mechanics of how it's costed. Yeah, and there's more to this than just the inpatient service provided by hospice. There's the community service. One of the things that we learnt, and I'm presuming Danny will maybe labour on it, was the value of a small number of community-based nurses. And the amount of people that they were able to care, and that is absolutely something that needs to be expanded upon. And if the neighbourhood model is a method for doing that, then well and good. But it's absolutely something. But, I'm going to leave on this point, and I'll hopefully get a chance to come back in later. But it is a bit disappointed. Some of the recommendations you've agreed with, but there's no plan. And that you're now coming here today and you're saying, well, we'll come back with more work. There needs to be a real sense of urgency to this. This is an important work for the committee, and we want to see real, tangible progress before the end of this mandate. So the things that we're talking about here, we want to see figures very, very quickly.
I acknowledge what you're saying, and I reiterate. It's an important area for the department as well, and we'll maybe come on touching on governance and how we're going to take some of these forward. But there is importance to sort of get the position in terms of recommendations, then give this impetus and have a really detailed implementation plan. I know we've discussed immediately on the high cost area, and that's rightly so, because as I said, when I met H Hospice, that was the first part of the discussion. But we swiftly moved on to the other areas that the committee has identified, both workforce, collaborative working, making the best of the community services, bringing some consistency and working collectively together. But as I said, I would break that first part down to three. How do we get additional investment in? Roger's mentioned how we revalorize for 2025-26. is it time to look again? If it was 2019, yes, 2026 is a time to review again what is the bed comparator, and then the third element is what is the progression rate and what makes it sustainable, because is it the 50-50 model on a different bed comparator? Is it an increase in percentages? We need to work through that, and we'll certainly be working through that with the hospice providers.
And we do want to see that trajectory of 100% over the 5 years, and then we can have the discussion with whoever about how we pay for that.
I think, I mean, we can certainly work out we'll work out the objective, what it would do to be 100. As I said, for sustainability, sustainable for the system, we also have to take in account of value for money and what costs provide. So, you know, whilst we can provide the figures, and that will be part of any modelling, what the recommendation would be, or the response to that is a different matter for discussion.
Value for money is important, patient outcomes.
Absolutely.
And the societal value is equal value.
It is.
Anyway, we're going to move on. Dan?
Yes, thank you, Chair. I read the department's response, and I suppose, like many people in this room, I was hugely disappointed. And from your answer so far to the Chair, I just get a sense of déjà vu. We've all talked about this funding. Is it the cost of a general medical bed? Is it a specialist bed? You went away to do some work on it. You've come back today and said we need to do some more work on it. I mean, we're just going round in circles, really. And to people looking in on this, it is very disappointing, because for all of us, all of our families will require support at this stage of our lives in one way or another. And it is extremely disappointing that this is the attitude of the department. And I've said this, and I know it's a bit out there, but we would never consider giving birth and leaving it to be funded by charitable donations. But we seem happy to do that with those who are at the end of their life. And it is actually, I mean, I may be a little bit, you may think I'm a little bit harsh. You're all very general, nice people and all the rest of it, but this is a very disappointing response. The hospice movement is one of the great movements, but hospices on their own cannot carry the burden in the way that they've been doing it. And if there is nothing else that comes out of this meeting today, I want to make that absolutely clear. The Chair has asked you questions of funding. I don't think I've really gotten an answer, whether you know the cost of a hospice bed or anything else. I mean, I'm not sure whether maybe I'm being a bit obtuse and I haven't thought about it enough, but I don't have an answer for that from what you've said so far, and I take it that you're now going to go back and do more work on it. But we've been going round this for a year, more actually. This committee has spent hours on end taking evidence on this, on a subject that is incredibly important to everyone, should be incredibly important to everyone, and yet, you know, we're all going to do more work on it. And I'm just sorry for the rant, but I actually am kind of a bit angry at the way that this has been responded to. It seems to me, taking in the previous conversation with the Permanent Secretary and looking at your recommendations, that 2% from the Trusts for Neighbourhood model of care is going to stretch to do an amazing amount of things. So how have you included the hospice movement, and I'll speak of the movement as opposed to individual hospices here today, in the discussions about the neighbourhood model of care? How will they access it? How will you ensure that there is a standardised amount for hospices, that there's a fair level of distribution of this 2%? And how is that going to work? How are people involved? If I ask the people who are sitting in the public gallery here today, how have they been involved so far, what would they be telling me?
Okay, Chair, I mean, first of all, I want to be clear, we're in no way dismissive of any of the recommendations and fully agree with what you've said in terms of looking at funding. I was trying to explain the approach, specifically looking at the cost of bed-based hospice care and the special palliative. There are 3 questions still to be addressed there. One was, what is the bed comparator? And yes, we have information provided by hospices. We've looked at benchmark information. Groves described the previous time that it was looked at, the evidence took us towards a general medical bed. And that has increased.
How long does it take to resolve this? I think we discussed this probably in one of our very, very first meetings on hospice. Yes. How this recommendation from us is not a surprise, shock, or anything else.
No,
you knew this was coming. So, yep. How long does it take to resolve this? I mean, I don't know. It's 18 months since we started the inquiry.
Mm-hmm. Well, I mean, I think I know it's Roger and his teams who look at the comparator. I think the first focus they had this year was to try and look at how they can increase the benchmark, increase the actual benchmark cost to put some money in the system, which is how they described it, 600k. I do agree we need to look urgently at reaching an agreement on, or revising and reviewing and determining what is the appropriate benchmark bed. And then there is a separate exercise, which I think is to articulate how much it would cost to move to 100% and whether 100% movement is the direction we're making.
If we were to come back to you, I don't know, in September, would you have the answers? Given that you've done all this preparatory work, would you have the answers?
You certainly have the answers to the 100% and what that would look like.
I think you've given us the answer to the 100% in this, other than you haven't estimated what the 100% would look like, would cost.
It would be the estimation of what that 100% would look like. And certainly we can go away and have a look at a revised cost comparator. That may well include working with our hospice colleagues. I know I've had these conversations with hospice colleagues to maybe cost it up around service specification, Dan, which may be the most sensible way forward in terms of estimate of staffing per bed, etc. like that. So it becomes unequivocal then and gives us opportunity to co-design that.
I'll move on from that, but I'll discuss with committee colleagues what we think we should do with that in the thing. There's 2 other areas that I'm really quite interested in. Well, I'm interested in lots of areas, but I'll not take up any more time than that. And the first one is the recommendation that you have completely ruled out, and that is any kind of help to Evora Hospice in the Southern Trust area for capital funding. Now, this particularly interests me, Jim, and I might sound like a broken record, but I'm not going to give up on this. We are throwing tens of millions of pounds in capital money around the place in the Belfast Trust. We are paying literally, as we speak, for water to be flushed down drains, tens of thousands of pounds per month. But there is no help for a hospice that is in a building that is very out of date. Goodness, I remember it as the St John of God's Children's Hospital from many, many years ago. How on earth is this a sensible way to operate health estates?
Well, I suppose two answers to that question. The first is the availability of capital funding, and I mean, I think in this period alone, the department's facing significant cuts to its capital budget and has already outsurpassed it by all bids, so we don't actually have a mechanism. The second is, what is support can the department provide? And I think support can fall into 2 ways. It can fall into actual capital grant, which I've said we just don't have the resources or funding available. And the second is, can we work with the system and with providers to provide some expert advice and guidance on accessing funding and looking at how other funding opportunities might come across. We talked about some of that in terms of Neighbourhood, and we talked about Marie Curie. But I know talking to colleagues in Evora that there may be funding opportunities, but again, they would like some support from the department in terms of assessing the relative benefits of those to the hospice.
Really not sure that answers my question, but I'm sure someone else will actually take that up. And the other thing I'm interested in, Gerard, when we started this inquiry, you came to the committee, I don't know, maybe January, February last year, and you said you were going to do a scoping exercise on what palliative care was available across Northern Ireland, which really astounded me that the department didn't know what it was funding or the totality of the care that was out there. Have you completed the scoping exercise? Will this committee be able to see the scoping exercise? Are there any recommendations from the scoping exercise? Where is the scoping exercise?
Sorry, thank you. I mean, I think the first thing to say is that when I was here, I was quite not cavalier, but quite optimistic about how quickly that could progress. So there's three elements. Scoping exercise is underway. There's three elements, three key aims to it. One is on scoping current provision. The other is on a needs assessment. So what the gaps are.
Sorry, because I don't want the chair to shout at me and tell me I've run out of time. You're saying to me that the scoping exercise is underway. I heard this last February. I heard it again at some other stage during the year. I want to know where it is. When will we see the scoping exercise?
The first part of it on the current provision, the initial report on that is due to us in I think it's in January of June rather. So that work is well advanced and is due to report very, very soon. We on the other two pieces, we haven't been able to make the progress on the needs assessment piece because, well, for a number of reasons, but primarily that is ought to be by rights a PHL-led piece, and they haven't had the capacity to work with us on that. And on the third piece on patient experience, we've been able to make some progress on that. So we've got data in on the NESL, and we've got we're part of a UK-wide bereavement survey by Mary Curie. So there's partial progress. So I guess good progress on strand 1. Partial progress in strand 2 and strand 3 rather. And strand 2 we haven't been able to progress, and so we are actively looking at how we can take that work forward. So when we will bring an update to the committee on the if we get our report in January, probably for your autumn session. I think we're actually due to report back on this in November, if I'm right. But I know you've written it, so we can cover it in the scope of that update. Or if you want something sooner than that, we can provide an update specifically on the scoping exercise.
Can I just say finally, in terms of pediatric palliative care, which is a particular interest of mine, there's very little promised in relation to pediatric palliative care. This is a lifeline for families. I mean, we're really failing families at a very vulnerable time in their lives for those families who experience immediate needs for pediatric palliative care. But there's families will require ongoing care who can't get it because of funding constraints. So will we be able to make that up in the neighbourhood model? Is there any, will the department compel in any shape or form the different trusts to come together to fund that regional paediatric palliative care piece?
I'll maybe pick up that question. I mean, I think if I can just say, first of all, the report has made a helpful distinction between the adult and the paediatric palliative care scene. I would maybe just ask for clarification if you're talking about the respite care support to families through the course of a young person's life or the end of life.
Both. And also that issue of transition. I had a very difficult case in relation to a young person who nobody seemed to think was their responsibility because they weren't apparently old enough for adult services, and they were too old for children's services.
Okay, and I'll maybe just respond on the transitions issue first of all. You'll be aware that's across children's services, not just the palliative group, but any child with it?
It becomes incredibly acute when you're told your young child has a limited time to live.
Yeah.
So it is different in different situations. I accept that, but I think that this is at the acute end.
And I just for context, I just wanted to say, as a wider issue, the transition of any young person who has a life-limiting condition is an issue of priority for us within the Child Health Partnership. Those who are on a palliative end of life phase of that journey are a particular subset, and accept that those are extremely complex. It's been estimated there's about maybe on average 7 per year who would fall into the eligible group who need a managed or a transition into the equivalent adult services, and in some cases those are better kept where they are if they're in that age where they're at a transition age, but maybe they're accepted to be in the last year of life. And those children are managed through collaboration between the adults and children's services, but accept that they're extremely complex, but part of a wider ongoing piece of work about how we better manage and also prepare adult services to have the capacity that they can adequately accept and treat those children. Those that are entering end of life during that age group, I accept individually they're all different, but they are managed primarily by the pediatric palliative care network, but working in conjunction with the appropriate adult services. I think I don't think you want to talk about an individual case, but understand we do hear of some of those that are brought to the department's attention.
Maybe we could, as a committee, see that piece of work or have sight of the outcomes of that piece of work, which would be very good. Can I say, folks, this isn't you're just here to do your job, but this is a serious issue which the committee has spent hours on end on, and which isn't going away. And the questions we're asking today are not going to go away, and we will keep bringing it back and back until we get progress in relation to what is really one of the most sensitive, difficult issues for families to deal with.
Yeah, I fully accept that. I fully accept, and we've recognised all the work the committee's done. All I can say in a general piece, everyone at this table here recognises the importance and criticality of palliative care. In terms of answering recommendations, you'll see that a lot are limited by finances. But what I can say is that as we work through this, we will continually be making the case for the investment that's required to help us deliver across a number of these recommendations. But it's making the case for prioritisation in a very constrained route, which does take us to look at where are there opportunities. The neighbourhood offers an opportunity, accessing new forms of finance offers an opportunity, and seeing if we can bring in additional investment. But throughout that, we will continue to make the case for best use of the resources we have and to invest to try and deliver on these recommendations.
Thank you, Chair.
Danny?
Thank you, Chair. Thank you for coming today, and I share some of the frustrations that have been expressed already. We first heard from you in January 2025 about the scoping exercise, and at the time you told us it would be 3 to 6 months. Now I think you had said you were a cavalier at the time. We're now nearly 18 months later, and you're telling us that one element of it should be reported in June. That's astounding to me. That and you can't even give a time frame for the second or the third bits.
No. I didn't mean to say the word cavalier. I meant to say I was overly optimistic in my initial assessment. I think I've been back since that January meeting, and to reflect that we hadn't made progress at that point. It's been much slower going than we anticipated. It's there's been to the people who are leading the work, and especially on that key M1, are doing a really, really good job, really thorough job. But we just haven't had the traction on it, and they're all equally important. The 3 strands. We're not going to pretend that one piece is then the full puzzle.
I hope you're not being overly optimistic today then, and you're being more realistic today than we're getting.
I think we've had this exact conversation last time.
And even that was a while ago.
January, the June date is when the first report is due on that first strand.
We'll see, and we look forward to. Can the committee see it in June? Would that be?
I don't. I mean, I assume so. I need to see what it is and what kind of format it's in. But I mean, we'll share, if not the report itself, any of the outputs either via a direct update or as part of our wider update on the progress on these.
I think we would be very keen to see the report, if possible, as soon as possible.
Well, there should be.
I could talk about this all day. It's a huge issue and it is vitally important. And certainly, the reason that we are so invested in it as a community is because of the value and the regard that hospices and palliative care are held in the wider community. Our constituents and people across Northern Ireland value this, and they want to see it funded and they want to see it improved because they know the high level of service that it affords people who are dying and have terminal illnesses. The neighbourhood model we talked about earlier, and I think the omission of palliative care services from the initial discussion, the development day of the neighbourhood model, I think that was an error because of how you described them as being an important part of it, yet you didn't invite them to development day. I think that was quite an error. I'm glad that you've now rectified that and you've committed to involving them in future development days and other planning days. I think that does show us the attitude of the department to the sector though, and I hope that improves. It does seem there is a bit of a distance there, and I hope that can be improved because we want this service to be improved.
I think Mike Hegan, it was a mistake on our part. I mean, there's certainly no slight intended or no disregard intended, but I mean, we can and should do much better in that space.
I certainly hope that's the case. I wanted to go on to the comparison. So my first question was about the comparison and the general medical bed. I don't get this. I honestly don't get this. I know the difference between a specialist palliative bed and a general medical bed, and they are completely different things. The level of service that delivered is completely different. So I think the committee would be very interested in seeing the figures that you have or that you're about to have as soon as you have them, so that we can do that comparison. And you mentioned some of the costs wouldn't be the same because the unit in Antrim is part of a bigger hospital. In my mind, their costs would be cheaper, because they would have access to, economies of scale that the hospice movement wouldn't have. So it should be cheaper to deliver that service in Antrim. Would you agree?
Well, I'll bring Roger who does the detail, but for me there's sort of two things about, and I don't want to get stuck completely in the beds and sustainable finance. So there's one element about sustainable finance, which is moving to 100% of the current funding model, and we can give you figures on that, and we have figures on that straight away, and we can cost it out annually. And as I said, in competing priorities, we will continue to make the case to try and increase funding if we can, because that will go towards making the system sustainable. The second question is, do you actually need to change the comparative bed, and is it 50% of a higher costed bed, or actually does it not matter if it's 70% of a general bed? Is that better than 50% of a comparable bed? So they're two sort of slightly different questions. In terms of, is it cheaper to provide it elsewhere? Well, that comes into the value for money as to how do you fund a palliative care bed. I wouldn't and couldn't critique your analysis of it. Is it cheaper in a hospital? It should be cheaper on a economies of scale versus overheads in a hospital. I wouldn't be able to do it. I know we'd have the PLIC system, which will take us down to a certain level, and I think all that I know from the teams who've looked at it is it's incredibly difficult to do. But I do think we need to bottom out the funding piece, and we're committed to doing that. One element of the funding piece is what percentage you pay, 50-50. The second of it is 50 towards 100. The second element of it is, what is it 50% off? Is it a general care bed or is it a specialist bed? In part, I think the two debates are linked to the same thing, and the same thing is, how do you get sustainable funding into the hospice? They're two different answers, but actually they're on the same route, and I think that's why when we said partially accept, we accept the outcome, which was you want to get the sustainable funding model for the palliative care beds that are provided, that are essential and are needed. And we all have the comparative data in terms of the quality that they provide.
Part of that comparison will be the staff. The staff in hospices are specialist palliative care, trained staff, clinical staff. In the unit in Antrim, are they paid at the specialist rate?
Don't have enough detail about the palliative staff, but Roger might have
If they're
that.
specialists, to be paid at a specialist rate, Danny. And again, that brings us sort of somewhere into the complexity of comparing, as apples and oranges. But your point made, given the economies of scale, should that be cheaper? I'm happy to share the workings that we've had for both OMA and Antrim with yourself, including the 25-26 Gen Med bed, which we openly shared with hospice colleagues, as you probably well know as well,
My
on
point
how
was,
we got there.
My point was more around pay parity, about staff within the hospice sector who are specialist palliative care providers, who are clinical specialists, and the staff within
If we're talking about pay rises or agenda for change,
yes.
As an example of that, we would traditionally play the agenda for change on the 50-50 split of the cost coming from the Gen Med bed.
You would consider
so we wouldn't pay the full actual cost, if you like, in that space. So it'd be based on the 50-50 component would be uplifted, Danny, by the agenda for change, or other cost pressures in there as well.
Do you accept that the specialist care providers within the hospice should be paid at the same, and as an element of pay parity, they should be paid the same?
I think some of that ties back into, if we're paying 100%, we'd be covering 100% of the costs. If we're paying 50%, and even if we get the bed rate right within the 50%, there might still be a challenge in there in terms of meeting all of their costs. But we certainly annually, as matter of course and routine, work with hospital colleagues where it be...
Just so I understand this, are you suggesting that palliative care, clinical palliative care specialist providers should be paid less in hospice than they should in the NHS?
I'm not suggesting that. I don't
No,
think.
I mean, I think
No.
part of this is it a public service, a non-public service? Obviously, the employers of clinical specialists in the hospices are the hospices, they are the employers. In terms of how we fund, Rodmer's described on the 50-50 model, we would on an annual basis look at increasing costs on that. Forget about the bed, but we look at the increase in costs and we pay 50% of the increase in costs. That doesn't issue any consideration about what people's value is or what their funding should be.
Ask Jim, you've mentioned a couple of times about value for money. Can I ask how we're determining value for money, particularly in terms of outcomes when it comes to palliative care delivery? Are there any health economists in the Department of Health?
There are health economists within the Department of Health.
How many?
Well, we have there's one in my group who's been working through various elements. We've been doing the hospital at home element of it.
Is a health economist specifically?
There are an economist who's looking at value for money but has experience in looking at health areas.
Are there any health economists in the Department of Health?
I'm not aware that we have a health economist under the title of a health economist, but we do have.
It is a specific.
Oh, it is. I know.
Area.
Yeah.
So you don't think there are any, or you don't know, or?
There's no. We would, if we're doing a particular study and looking for health economists, we usually would bring that support in.
Okay. And have you done that for palliative care?
Palliative care in its entirety, no, we haven't. As I said, we're looking at the scope and exercise, breaking down those three elements. However, what I can say, we haven't done that for any individual service. As a system and as a department, and I appreciate the criticism from the committee that there is a definite view that the department is significantly undervaluing the hospice and palliative care system. I mean, I can say as many times as possible that we fully value the service provided. We accept the recommendations and we're working through implementing those. It'll be difficult in financial times, but it's not a difficulty caused by the fact that we don't value the work provided. We don't understand the quality of the work provided, because we certainly have our Regulation Quality Improvement Authority and its advice on it. It's working through how we do that. One of the issues is around governance, and we might come back to that.
Sorry to interrupt, Danny, but in terms of, I mean, name another service that the healthcare service provides that doesn't fund 100%. I mean, if you're saying you recognise the value, so I mean, is there other services within the healthcare sector? You know, Dan mentioned birth. You know, children are born. You know, is maternity funded 100%? It is. No, every other service within healthcare is funded at 100%. So in terms of recognising value, I think the simple way that people can understand value being recognised is if we move towards 100% funding.
I think move towards 100% funding, as we know the recommendation, that's in terms of percentages. When you talk about every other service being funded, and I suppose it reflects all of it, every other service is funded at a commission level, but you'll be aware, and the Permanent Secretary discussed and the committee discussed as well, that at the moment we're indicating or estimating a funding deficit this year somewhere between, and I'll use a range so I'm not distant, I'm not time anywhere, somewhere between 690 and 800 million. So therefore, as we stand, the department's facing into a fiscal year knowing that we're somewhere between 690 and 800 million short of what we need to fund the entire system. So even when we're saying, do you fund all your services? Every service, and I'm sure you'll hear from every specialist, you'll hear from maternity services, you would certainly have heard from emergency services, you'll hear from domiciliary care, all will say that they have not received complete funding. The issue we're talking about is the methodology that we have for commissioning the hospice sector, and I think we're all agreed we will look at that, and the outcome that we all want to achieve is a sustainable funding model.
Go ahead, Danny. Sorry for that.
Just to go back to the health economist, I'm stunned that there isn't a health economist in the Department of Health, which gets 52% of the budget. So, we don't have a specific health economist, which is a speciality within the department, who are looking at outcomes, who are looking at value for money, and you say you can bring services in when needed. Surely this will be part of the scoping exercise, will it?
Yeah, I mean, I'm not getting the question here. We have economists in the department, so wherefore when we're looking at any business case related to any service, we look at outcomes, objectives, value for money, including the value for money that isn't about cost. Value for money is also about quality, improvement outcomes, and better delivery. So all those are considered as part of it. If we needed a specialised
health
advisory.
is about the speciality of having a health economist, which is a speciality in itself.
It is.
And there is nobody within the department who sits at that role.
I think what Danny's saying here, if I can simplify it, is an economist looks at figures.
Yes.
An economist goes to university, they spend about every year, they're looking at figures. A health economist is somebody with an additional speciality where they're not just looking at the figures, they're looking at outcomes from a health perspective. So I think we all share Danny's kind of stunned
and maybe I'm
amazement.
doing a disservice to our economists, because our economists will look at they'll compare the outcomes that are achieved in terms of health outcomes to it. I mean, when I was speaking to health economists,
happy to move on from that.
So one of the health economists I was speaking to was actually looking at the economic value of health as opposed to health outcomes.
Happy to move on from that just to the clinical lead to recommendation 20. Now, I'm glad to see that you have accepted that. I just wanted to ask about the delay. Now it says in recommendation 20 that you've accepted that the department hopes to have commenced the appointment process in the next 6 to 9 months. What's the delay if you've accepted that as a recommendation? What's holding that up from getting that out as soon as possible?
I think it's not simply a matter of moving to appointment. There's no agreed job description for what this person, just specify what the person will do. So there's an engagement piece to do with the sector, with this chief medical officers group, with other people to really make sure that we've got a clear sense of what role this person is to fulfill, what sorts of qualifications, experience is going to be necessary to do it. And then we'll move into an appointment process. I mean, there is time built into that. I accept. Also there will need to be a business case developed because it is going to be a new role in the system. So having clarity on what they're to do. So there are process bits that need to be done before we can move to an appointment process. But we are going to actively pursue that.
Will it be within this year, do you think?
Well, that's what we're working towards.
Okay.
Okay, thank you, Colin.
Thank you, Chair. Thank you for the presentation. There's a few things are certain. One is that you'll be glad to get out the door after this session. It hasn't been fantastic, and I appreciate that. I probably have a sense that in terms of the department, there's no extra funding coming here, and yous are being sent in to try and defend accepting a whole load of recommendations of one half, which, I mean, I know that these are all human beings. Of course you say palliative care is important. Of course it's important that it's funded. Should it be funded 100%? Of course it should. This is when people are dying. This is about what we do to help and assist people when they're in the last moments of their life, and to do it with dignity, and to do it with care, and to do it to the best of our ability, and it's really impossible nearly for you to come in knowing that there isn't any extra money and then say there's 27 recommendations and we accept or partially accept 26 of them, and then whenever the next inevitable question is, well then how are you going to implement that, say well we don't have any money. So there is a conversation I think that there needs to be, and in fairness to yourselves, I don't think that it's yourselves that has that conversation. I think there's a, spending decisions are political decisions, and therefore in the department there's a political decision at the minute that has to be taken about whether to fund this or not. And on that then I suppose the simple question, it might be one of the easiest ones today, is just how much additional money is being allocated towards palliative care services in the next year on the basis of the recommendations from the report?
Well, I think the Permanent Secretary made it clear we're in a very difficult stage in terms of those budget decisions, and there are three elements to that. One element is we haven't got a finalised budget, so therefore you're talking in theoretical terms. So what are we doing in theoretical terms that ask this? Well, theoretically in terms, we've asked trusts to begin to plan to try and find efficiencies, but also to begin to plan to deliver what we consider to be strategic priorities, and this is before we get to funding. And within those strategic priorities we've identified palliative care. One of the methodologies of doing that will be looking at the shift of 2% of activity and 2% of funding, because obviously if you're going to shift that you need to have somewhere to shift it to, and our hospice providers are major already providers of that commissioned community care basis. The second element we've said in terms of priorities that you should be considering is to look towards us identifying as a department what are our priorities that we need to fund before we look at the deficit, and we've done some thinking of it. Obviously we're looking at pay, but we're also looking critically at some of these palliative care recommendations, and some of them we say subject to funding, subject to business case. These are ones where we've already made strong cases for funding. Some of the ones that Roger can describe around the 24/7, some around expansion of the hubs. Those are plans that we have in place and are saying internally, but we can't resolve those discussions till we know what the budgets are, until we say here is what the trade-off is. But and I think I tried to make the point, in the department we fully recognise the importance of palliative care. We recognise the value of the recommendation made by the committee, because they are recommendations that are really, really important. We don't criticise the value for money for the service, but it's areas that we want to invest in. We've made the case in terms of planning that we want our trust to consider palliative care to be a strategic priority. We are now going through our own internal process about what are our priorities for budgets that we need to spend. I do have to say it's a difficult choice, because by making something a priority when you've no new money, you're making something else either less of a priority or somewhere that has to find more savings. But we're going through that, and we recognise it in palliative care. That's why Garrod's able to say the challenge we have around the appointing a clinical lead is the process, not the funding, because we're going to make the case that that's a priority post for us to bring on board. And the only other area I can reflect in terms of investment is going back to the neighbourhood model. Obviously we'll be setting those management teams up in place, and there'll be 17 of them, but we are quite clear that one of the areas that we say as a priority is elderly. And I mean, there's some, I know Mike quoted the Nuffield Trust, and there's some other interesting figures in the Nuffield Trust where they reflect on the amount of money that's spent on the last year of someone's life, which is I think in excess of 500 million, and they're saying 200 million of that is on social care, but they're saying quite a lot of that is on health care, and quite a lot of the money that's spent on health care, of that close to 300 million, is spent in acute, and quite a lot of the acute is spent in emergency departments. So that immediately starts to say, A, it's not the right place, because that's not what any of your findings are, and there must be ways to deliver a better service and spend money better. But those are difficult conversations because they take a time to move, and every area is under pressure. So whilst I can't answer how much additional are you putting to it, I can say we've put it as a priority in our funding. We are working on funding plans that prioritise it, but these will have to be considered in terms of the wider budget, but the cases will be made.
Just to add to that, I mean, I think in terms of, like, if you take a step back from what we're trying to do through Neighbourhood, a lot of it is about the secondary prevention, trying to keep people away from hospital and safe in their homes and communities. And palliative care fits exactly into that space. I mean, it goes through the centre of it, like the kind of the thinking behind it. Hermsec mentioned one of the things, there's an additional funding opportunity that we're working with Macmillan on to try and maximise, to bring in new money in, effectively to pump prime some of the shift that we want to see, because it's very hard to make a change in a place where there's no additional money. So, and the models that we're looking at, and Macmillan have been really, really supportive in this, are looking at, proactive care models where people are identified earlier, are given support earlier in their journey. Then you measure the impact by a reduction in unwarranted bed days. So there's a mechanism built into it for where you will reduce costs in your system, and therefore how you will repay the funding that's provided up front and make it sustainable in the longer term. So that's that in the context of a 8 billion health budget, 10 million isn't, or 10 to 12 million isn't going to change again, but in the context of these services, that's significant money. They can make a real difference, and we've got people working with us who've done this before elsewhere, who really know what they're doing and have been very supportive in that space.
And look, I'm just going to leave it at that. Is that I remain guided by hope and faith in that, because if we're talking about the neighbourhood model as being pretty much the main way we're going to see additional funding here. If we take something like palliative care and say that people are dying in emergency departments, so we want to move money so that they're in the community and in their homes, I don't see any trust reducing their emergency department cover. They're not going to get smaller, there's not going to be less staff, so where does the money actually come that's going to transfer out? Likewise, I don't see there being a reduction in the bed count that we have, because the bed count across Northern Ireland hospitals is at the lowest it's ever been. And I think that if we start to shift services out into the community, and then the theory is that we say to the trust, well, then you can close a ward down because you've moved all those staff out in the community to do things. I don't see that happening either, but I hope that we could just get the stage where the money goes out. But
I think that this is the really challenging area we are in our journey of transformation, as the Permanent Secretary's described it. It would be great if we were doing this with 200 or 300 million and saying we're going to fund these new services, and therefore they will take the pressure, and the pressure can see reduced areas. What Garot's described in the possibility with Macmillan funding is a bit like that. It's saying here potentially 10 million for you to put a service in place here that over a 3-year period will reduce your demand here. You can then pay back that social capital because you've reduced demand. And when we talk about reduced demand, it may not be beds. I think there's the excess beds, we call corridor beds, but it's also the excess beds come with an excess workforce, which is manifesting itself either in significant agency costs or significant locum costs. So there are funds that we are saying, well, if you can reduce a demand elsewhere, that should provide the funding to deliver it in a better way. But none of it's easy, and hence some of our uncomfortable pullings of the collar when we're being rightly challenged as to how we're going to deliver on some of these recommendations.
Thank you.
Alan Robinson.
Thanks, Chair. This reminds me a little on the adult protection bill, whereby there will be a lot of disappointed people on the back of that piece of legislation becoming law, simply down to the fact that there is going to be not the available money in order to deliver the adult protection bill. And it is a very important piece, and very important to a lot of people. Similar to this, internally I predicted that there will be disappointment on the back of this, and there is indeed, not just in this room, but out there in the wider community. Cognizant of the very difficult financial climate that we do operate in. However, Danny had raised recommendation 20, the clinical lead. So, will that be a clinical need or an interim clinical need? And has there been any thought of implementing an interim clinical lead in the meantime?
Yeah, I mean, maybe to give it a bit of context, it's critically important that all our thinking and all our service considerations are informed by clinical expertise and clinical advice and guidance and policy and strategy development. We normally do that through having a clinical lead, and the recommendation was we need one for palliative care. That's not to say at the moment we have no clinical input into our policy and strategy. And in the interim, while we're pending appointing a clinical lead, we will be using our existing mechanisms, which includes our clinical engagement group and a palliative care and partnership structure. So it's not that there is no clinical input into any of our thinking or any of our policy and strategy, that it's not done through the recommended approach of appointing a palliative clinical lead. So rather than an interim, because quite honestly a lot of our appointment processes would take the same whether it's interim or full, what we're doing is we'd be relying on the extant clinical engagement forum and palliative care and partnership programme.
Recommendation 27, Jim, referred to bringing forth a strategy. So, have you a timeline on developing a strategy and an action plan therein?
Two things. I think our priority for a strategy as identified by the committee should be to bring forward a palliative care strategy, primarily the adult one. Our children's strategy, actually, I think Ryan came right, maybe has still 1 year to run. Our minister, rightly so, and I think so have committees, and rightly so, in a number of areas have said, listen, strategies are great, and you should develop a strategy, but sometimes we want actions, and our approach to a number of recent challenges we've had, particularly around maternity, neonatal, and around, I think, women's health action, and including, I think, the approach we might take to the refresh is to do a quick refresh to get us an action plan that will take us forward for a number of years. However, on the children's side, I think on the adult side, we do need a strategy, and I think I'd be very keen that we put in place a structure to help deliver that. And I know colleagues in the hospice sector have already started some work in their thinking about how they might inform and work with the department to develop that strategy. So I think on the children's side, but Ryan might come in, my initial thinking would be we'd be better going for a look forward to take us a couple of years in an action plan rather than pause and do a fundamental strategic review. Ryan, do you want to say a bit about that?
Just on the children's palliative and end-of-life strategy, as you may know, was published 10 years ago alongside our children's community and hospital strategy. So they were developed and published side by side, both with an end date in mind of 2026. So this year we are now turning our attention to what comes next with those. The palliative and end-of-life one is quite a big strategy, a smaller group of people involved with it. So we will be thinking about what is required in order to replace that. A lot has been achieved under that strategy with very limited funding, I should say, particularly with in 2019 the establishment of the pediatric palliative care network. Now it has a funded regional clinical lead already in place, and that's vacant at the moment, you may be aware. There's been some challenges with filling that, but there's a renewed effort to get that filled, and that's a key post for driving, and has the previous occupant of that post led a lot of work bringing trust together, developing pathways, and in addition to that you have a clinical lead based within each trust who is funded at a 1 PA per week, 1 programmed activity per week. Arguably could do a lot more if those roles were expanded, and that is what the network would like to achieve. So main point being, just with limited funding to date, the network has achieved a lot in terms of collaborating, working together as a system. They're working at the minute with the adult leads and with their commissioners in SPPG to work out what are the models of care that would enable us to respond to the pediatric recommendations within this report, and how we renew the strategy to support that work will be done hand in hand.
Well, you've kind of answered the question regarding the pediatric palliative care consultant, but what has happened to the funding that was available for that post?
It's still in place.
Still in place.
It's been a challenge of
Okay.
just recruitment for various reasons.
Okay.
So it hasn't been withdrawn, if that's your question. It's just that the post has been vacated and it's in the process of being recruited to.
Final question: when do you expect the full rollout of just-in-case boxes across the trust?
What, sorry?
Just-in-case boxes across the trust.
Really well advanced.
That's currently being rolled out at the moment. As you know, I'll come back to you with a final end date on that, but that is live and progressing.
A lot of these areas.
I'm happy to follow up on a confirmed end date on that.
Colleagues will be aware, members will be aware from the briefings we've had and big discussion last year when we were starting to look at winter planning. A lot of the big discussion recommendations started to focus in on the palliative care as areas that we could do some active work in terms of relieving pressures over winter, particularly ED attendances. And I think a lot of these recommendations, particularly, for example, just in case boxes, are all things that we want to have and make sure we have in place for this winter coming and be rolled out as soon as possible. But we come back with a specific date for that.
Alan first.
Thanks very much. Gentlemen, I promise this is not a leading question. I just want to give myself a better understanding of the methodology that you deploy to arrive at the figure of what it costs to service a general hospital bed. So is the figure just a patient in a hospital bed and getting water and fed and a nurse attending to their needs? Or does it take into consideration that some patients would require more medical and more nursing care than others? Are drugs that they're supplied with factored in, or is that completely separate sort of budget line? And the rate that you come up with, does it differ across trusts? And even within trusts, does it differ across wards? And I know in the Ulster Hospital, I'm sure it hasn't changed, but I know some time ago, each ward was expected to service 2 corridor beds in each ward, with no additional nursing staff, just the people had to work a little bit harder. Would that skew your figures, that the fact that there's a number of corridor beds? Does that...
I'll bring Roger in on some of the detail behind it. You know, our objective is to try and come up with a single figure that we're able to use across the region, taking as many factors as possible, but Roger will give you some detail.
So the cost that we come up with would be our HSC average, if you like. So that do they vary between trusts? Yes, they do. Do they vary between wards within hospitals? Yes, they do. And do they vary within the same specialties between trusts? Yes, they do, because of some of the factors that you talked about in terms of skill mix, in terms of just bed composition. Some wards, maybe 14 beds, etc., maybe have a different skill set. Other wards, 12. Okay, with again a matching team. It's all total costs in there, as far as finance can break those down for us. So those would be fairly standard cost comparators that we would use across all wards and all inpatients across all of our hospitals, but we would pull out the Northern Ireland average, and that would be the currency that we would use.
Does it include in the price of drugs?
I'm happy to come back to you on the price of drugs. My understanding would probably be the staff.
Just the staff costs,
in that.
Yep.
I think
Okay.
pharmacy may be separate,
If you
but
maybe
I'm
could
happy
come
to
back
come
to me on
back.
that one, would you?
Yeah.
Thank you.
Are you on?
That's me. Thank you, Chair. Thank you.
Just a couple of points, and Dan mentioned ever hospice, so I mean you answered her in terms of capital cost, but the recommendation was kind of went beyond capital cost, that the department should work with the hospice and support its move. So, I mean, going beyond the capital cost, I mean, we're a bit disappointed that the department have blankly refused that recommendation. I see no reason why the department wouldn't engage with that hospice to support it in its move. You're studying.
I'm studying because we indicated I'm able to accept what I've said and actually said it to for hospice. You know, I'm open to having any discussions about what support we've been. I've said the difficulties with capital, but I'm open to have any discussions as to what support might be helpful from the department.
So the department will continue to engage with EBRA
in terms of supporting their considerations and their deliberations, and any advice we can, and I've even mentioned whether we can provide support in terms of different funding models that might be available to charities to access. We're happy to do that.
Okay, fair enough. That's simple. In terms of the 24/7, because somebody else asked in relation to, I mean, that was another issue, because there was a lot of stuff come to us, and we kind of have focused disappointingly on funding today. I mean, there's a lot of other things. So the 24/7 support, I think, was a key component of the evidence that we got. And I mean, you've accepted that recommendation, but it's like a lot of these things, we're not getting any definitive timeline. So some of them cost money, yes, some of them actually don't cost that much money, but is there kind of any definitive timeline when we might see the overarching 24/7 support?
I'll ask Roger to come in.
Essentially, the heart of that is that 24/7 access in the regional hub. Chair, is that in terms of the out of hours?
Yep.
Is that we have a timeline over the next 6 months to begin to scope the potential of a regional 24/7 hub.
Just hold it, go back, because I'm smiling here. Within 6 months, you have the potential to scope. Okay. I mean, this kind of just completely blows my mind.
Okay.
I just want to know, in month, this will roll out. Are we going to get that information?
They have to do a lot of learning from the Belfast hub.
Okay.
Which will obviously inform any service design of the regional one. The regional one is a firm direction of travel to complement the neighbourhood model, etc. A single point of access that covers the out of hours, hugely vital for those families and individuals that access that. So yes, the ambition is over the next 6 months, drawing on the learning from the Belfast hub, is that we get to position to write up the specification for our ambition in that, but it's still...
If I maybe say, I mean, I think I get the frustration from the committee in terms of our response. This is your response. This is our response to recommendations, and they've gone along the route of accept, reject, partially accept, and given a bit of flavour of what we're doing. One of the things that we are clear about doing, and it's one of the recommendations, is looking at how we as a department organise around palliative care and how we support palliative care and strategy and policy, which, as you pointed out, has been a bit disjointed in the department. One of the commitments we've made is that we will be creating a palliative care team to look at all aspects of palliative care in terms of policy, strategy development, also working with our operational colleagues in terms of how we deliver it. I think the networks for operational delivery are more advanced than the policy and strategy teams are. One of the key asks, I think one of the things that will be happening early on is developing a detailed and time-bounded implementation plan as to how we take forward these recommendations, which we would share with the committee, probably acknowledge that it's well below what your expectations would be in pace, but at least we'll give you the timelines and then we report progress on it. In doing that, I will be wanting to draw on experience I have with other areas, in particular things like as important as the cancer strategy in terms of some of our elective care strategy, where we pull together a group that's made up of clinicians, experts, stakeholders to help shape that strategy and implementation, but B, also be a sounding board that we would take ideas in terms of recommendations, timescales and prioritisation. And as part of that group, we will certainly be involving our colleagues in the hospices at that strategy piece. We work well. We have a cancer strategic advisory forum. We have primary care, a strategic advisory forum. And I think we need to ensure that the palliative care development of strategy, policy and implementation of these recommendations is given a significant profile.
I mean, I understand that none of this can be done quickly. We would like to see it done quicker than we're kind of getting here. So, I mean, there's just not an alignment of expectations of how important and how quickly we want to see movement from what we're getting today. And at the risk of tempting fate, another issue that came up time and again at our evidence session was advanced care planning and the respect. Mm-hmm. So when can we see that implemented?
Interestingly, that's linked. So I have responsibility for advanced care planning as well, and with the Chief Medical Officer, I share the frustration at how long it's taken to move for what was a co-designed and very well-received policy and strategy document into full implementation. And part of that challenge has been resourcing and prioritisation and capacity within the PHA. I asked the PHA to prioritise this and take forward and develop an action plan that would allow us to implement all aspects of advanced care planning, both the respect element of it and already we've made some progress. So there's been quite a bit of training done, level 1, level 2, for primarily hospital staff and indeed for care home staff, and we made that available as part of the big discussion on advanced care planning. We're also working with the Encompass team to make sure that we prioritise getting the electronic version of the respect onto the system so that everyone can use it. And PHA have now appointed a programme lead to develop an implementation plan for all aspects of advanced care planning. Part of it is I asked them to prioritise that, which meant they didn't have the priority to apply to strand 2 of the scoping study, because I asked them to say prioritise moving forward and bring me forward a detailed implementation plan for advanced care planning. I expect that to come to me within the next couple of months, and we'd be more than happy to share the implementation plan. But that's not to say work has already progressed, both in terms of training, in terms of prioritising the medical element of it. We had the team out, I think, with the committee, who were looking at the medical standardisation pro forma, and that's the same team will be looking at it. And we're doing quite a bit of work with Encompass to ensure that we have the digital system to back up the implementation.
I wanted on again quickly.
Thank you, Chair. Yeah, just a couple of things. The first thing was just the palliative care strategy. I think the last one was 2010 to 2015. So we're 10 years past that. So it's good to hear that we have a commitment to bringing one forward. You mentioned the big discussion there a couple of times, and I just wanted to ask you, were palliative care providers invited to the big discussion? Marie Curie, Hospice NI, were they part of the winter preparedness plan?
I need to check the detail of attendees. I didn't manage the attendees, but palliative care was a critical element of it.
Should have been invited.
They either should have been invited, or have been invited, or have been, or should have been part of the implementation groups that are looking at elements such as respect to advanced care.
Found out and replied to
yes,
this, and
well,
do you think they should be invited in future ones then, given how critical a part they are?
The big discussion is moving into distinct implementation projects rather than an ongoing recurrent event, because it's identified key elements of it. So part of big discussion is advanced care planning. That'll be moving into the advanced care planning implementation phase. Part of it would be looking at elements that will move into frailty within the neighbourhood model. So it's no longer going to be taken forward as a sort of separate item. Rather, it's
briefing on it later on. So
that's okay.
Anybody else answer that? Does anybody else know?
Sorry, what?
Does anybody else know if they were part of the big discussion?
Like we're working across the logistics of that process. So
no problem. Okay. Thank you, Chair.
Okay. Thank you. So anyway, you're not going to be surprised that we're not totally disappointed, or we are not totally satisfied with how this has went, given the importance that we have. So there's a number of items there: baseline report, the budget for palliative care, the working cost towards 100%, the bed comparisons, the more detail in terms of palliative care involvement in neighbourhood, some of the other things, then laterally the just in case boxes, the 24/7, the advanced care planning. So I mean, we do thank you for coming and giving the evidence. I might make a recommendation when you leave that we actually invite you back with firmer updates and timelines on some of this stuff, quicker than you probably want to come back. But this is important for the committee, and we're not going to take the foot off the pedal in terms of that. So I'm going to make a recommendation. I can't say until
that's fine.
You leave and the committee give me the go ahead to do that. But
sure, what I think would, with your leave, if we had, I would like to take the recommendations and not report them as recommendations, put them into an implementation programme that has times, deadlines and progress, and come back if I had time to talk to you about our implementation plans.
And that, and essentially that is, but as I say, there's a difference in alignment and how speedy we want to see these things. Then so
appreciate that.
Anyway, thank you very much for coming.
Thank you.
Okay, members, so just on the basis of that, conversation, I think they are scheduled to be back in November.
The plan would normally be, Chair, that we would have them an update every 6 months.
Okay.
But it's up to committee to
decide how to take that forward.
I mean, my view is that, I mean, there was an awful lot of stuff there that could easily have better informed us, particularly of time frames on implementation. Some of that costs money, some of it costs very little money, some of it doesn't cost any money, and we're getting the same kind of answers on the back of that. I would be suggesting that we, now that they've picked up on those issues and know that we're expecting a bit of urgency, we do get them back sooner rather than, I mean, that we don't leave this 6 months. I think the hospice and those who are working in the palliative care sector expect us to push this issue. So I don't know what people's views are on it.
I agree. I mean, blind man, the galloping horse could have seen when we started this inquiry that we were going to come out with recommendations and the department was going to say it didn't have the money to implement it, but we've got that now. But I think we should at least write to the Minister and say, certainly nothing against those presenters come in to present the information they present. They're given the information to come in and present, but I think we should be asking the Minister, is it his intention at all that additional funding would be made available for this, for any of the recommendations out of our report, and if so, how much, and gauge, because if there's no money, there's very little point in talking about half of them.
Yeah, well, but as I did say there, the Minister does always on occasions tell us what he wants, what we want him to prioritise, and in this instance we have told him, and there are announcements regularly where the Minister does offer additional money to additional services, and as I say, some of this doesn't cost that much. So like if they would come to us today and said, you know, here's a timeline over a 5 to 10 year period, this is what it's going to cost, and this is over the period of time that we will implement it and add those additional costs, I think there would have been a different atmosphere to that. But to come with little or no time frames on any of it, I think is the disappointing factor.
I think we should be clear about what we're asking them to come back and do, because I also just get a wee tiny sense that they maybe weren't expecting to be asked that today. I think they were thinking that they were just going to talk about the report and what they're expecting or not. Whenever we started asking about timescales and implementation plans and where the money was coming from, you could just see the whites of the eyes were going, and that's, you know.
Well, they're clearly aware of it, and I did reiterate what would be inviting them back to ask. So, I mean, I do think we should write to the Minister, and I do think that we should schedule that session again and expect time frames. And as I say, you know, if there are costs put to it, then at least we know what they are. Happy with that?
Yep.
I mean, the other thing is that the committee staff, there's a draft statement here just on the back of that expressing our disappointment. I don't know if did people get copies of it?
No, we've got
going to get a copy of it now. So if people want to get a copy of it, just take a couple of minutes to read and see if they're happy enough, content that that is issued from the committee.
Oh, thank you.
Just while you're reading that, just to let you know, we're going to publish the department's response on our website as well. Are people content with that?
Yeah, just the only thing I would remark, and you'd probably expect me to say this, Chair, is that the we're calling on the Department of Health, but they alone can't find this or provide this resource. We're sitting at the moment without a budget. That's the responsibility of the executive. And certainly we're looking for the 3-year budget. So, I think that surely we must include some reference, even as a passing reference, of calling on the executive to step up to the plate and come up with a budget that would enable the department to revisit their resourcing of palliative care. But I don't think. I think if we're going to fire darts, I think we should be firing on about everybody that has responsibility in this.
Though, Chair, had there been an agreed budget, that the response from the department probably wouldn't have been much different. Sadly.
Yeah. I mean, I have no difficulty. I think we've all want an agreed budget. I think the executive should agree a budget. I think the executive probably agrees that. But I mean, it is the Minister of the Department of Health who's responsible for agreeing for funding services within the department. I mean, I don't care. I'm easy if there's a line goes on about the executive agreeing a budget.
I think they should. If there wasn't a line, I would disassociate myself from that letter. I think it's necessary to put
the last sentence, before the last sentence, the health minister and the department. I think the committee urges the executive to agree a budget, and the health minister and department must now ensure.
Fair enough. Yep.
Are people content with that?
Fair enough.
Yep. I don't know if Diane will be content, but would it be better to email that out and give a deadline for tonight?
I think we have to agree it now. I mean, it's if we go. I mean, if the media, if we're issuing a press statement on the back of the committee meeting, we'll have to do it. You're in charge of the. I mean, all we're saying is we would encourage. I can't remember what I said. They would encourage the executive to agree a budget.
Even I think in their own words there, that where it says, but said that instead of the current health budget, it said that in the absence of a healthcare budget, they cannot support the delivery. Because I think that's what they said. They said in the absence of it, we can't commit it, and that's not really kicking anybody. That's just a fact. In the absence of one, they can't do it. That's not saying it's anybody's fault. It's just saying it's not there. Therefore, they can't.
Yeah. Though the line, Chair, is still giving a bit of false hope that all the magic is going to appear whenever there's a budget agreed, and all the ills of the world and the panacea is going to be there as a cure-all.
No, I mean, we're going to conflate beyond this. So, I mean, I think every minister wants to agree a budget, and we do want to agree a budget. But when we do, if we do, it still is up to the health minister so I mean, I don't see any harm in saying something that every MLA, in my view, should be saying, that we want the executive to agree a budget. I mean, who's going to say we don't want the executive to agree a budget? I mean, I'd say no. Everybody, we're politicians. We need a budget, so we want the executive to agree a budget.
We can't leave it unsaid.
Yeah.
We can't assume that the public realise that. I think we've got to say it.
Yeah. Danny?
Can I make a suggestion, even to shorten it? The Health Minister and his department must now ensure that the resources are put in place within an agreed budget to support palliative care services that fit for purpose. Would you be happy enough with that?
No, because I still think that it's the onus is on the executive to provide a budget.
I mean, I'm proposing this. If we can't get agreement this, then
the minister at the moment can't deliver anything. If you look at the facts and when his budget's going to run out and how much of it he can spend between now and July and all the rest of it, it's not fair to put the onus on him to find what we're asking for to support a palliative care service as fit for purpose. Of course we want that. And I'm sure the minister wants that as well, but we'll have to give him the tools. We don't. The executive have to give him the tools to do it.
So anyway, I'm going to propose before that sentence that the Health Committee encourages the executive to agree a budget, and the Health Minister. So can we get agreement on that?
Yep.
Okay. Straightforward. So the Health Committee encourages the executive to agree a budget. Right. Okay, we'll get that issued. Moving on then. Item number 7, which is a written briefing from the department on home care service. So can refer people to page 111 and any comments. So obviously this is a major issue. It's one, as we continue to say, isn't going to go away. It's just going to get worse. And again, we do need some action I mean, we all are aware of the media speculation this week that in rural services some independent care providers are going to pull out. So I think it's important that we got an email. I got an email from the independent care providers last week. I think we should forward that again to the Minister and ask for an update and make sure that there's continued engagement with that sector and with home care providers, that we work on that service being protected. Content? Colin?
I absolutely agree, and I think it's, again, we're going to end up, a number of us here represent rural constituencies and are going to be the ones that are being specifically earmarked for being impacted by this potential reduction in service. But I mean, I raised the question as the topical question in health questions and was told there's a clue in the fact that there's an 800 million gap in the budget. That wasn't very helpful in what is a very serious issue. So if we could write to the department and ask for that, it would be worthwhile, because we need more detail than clues. We're MLAs, not detectives.
Okay, item number 8, written briefing from the department on the mental health strategy. So can I refer members to page 120 of the main pack? And I do believe I have some commentary on this. Does anybody else have any commentary while I'm bringing it up? I mean, I was just going to reflect the concerns by all the organisations that we meet in our role within the community and voluntary sector. There's absolutely a disconnect between the strategy and delivery. And I mean, that the mental health champion identified that clearly a couple of weeks ago in terms of her report and evidence gathering. So I mean, there just needs to be continuous engagement again between the department and those working on the ground to try and address some of the gaps. Danny?
Chair, I know you were at an event with the mental health champion recently, and her frustration with the inability to deliver mental health strategy means that people are being failed across Northern Ireland. This suggests that targets are not being met, and I think there is a big mismatch between what has been reported and what should have been reported, what strategies are in keeping. I'm just wondering who is responsible for these missed targets. Where does the accountability sit? We're a scrutiny committee. We're getting this, we're looking at it, and we're saying, target after target after target is being missed here. I think, it's some of the achievements that were listed in it as well. I thought were quite concerning. I think there was achievements about writing job specifications. I don't necessarily rate that as an achievement. I think that's a task that somebody should have been tasked to do. I wouldn't consider that a particular achievement, but it just seems to me that we're not given a clear line of accountability as to why these targets are not being met. Yeah.
So can we write back to the department just seeking additional information in relation to the targets?
Because there's a number of them that say that work has progressed, or work's nearly there, or work's fine. It'd be good to get slightly more information than that, and I think we owe it not least to Elodie that was here last week that gave us a very clear and comprehensive suggestion as to how it's impacting young people. So I think we need to get some of that update, that we can at least be responding to those calls.
Okay, so item number 9, written briefing from the department on the Inquiries Implementation Programme Management Board. So that's at page 131 of the main pack, if anybody has any comments. No? Okay, item number 10, written briefing from the department, Winter Preparedness Plan 2026. So that's a written briefing at page 170. Danny?
Winter preparedness, we talked about it a lot over the last year, and there were various meetings and big discussions, and we heard today about it being referred to again and again. It failed. Things got worse. We've heard that A&E 12-hour waits were up 14% from March 2025 to March 2026. That's a shocking increase, and we know that relates to excess deaths and more than 1,000 excess deaths a year for the last 3 years. So things are getting worse by 14% in our A&Es. Our 12-hour waits are getting worse. I think that's an absolute abysmal failure, and this report just highlights that. The winter preparedness did not work despite all the promises of it.
Do we have a scheduled, I mean, is there a scheduled briefing in relation to that in advance of the winter coming?
There's a scheduled, at the minute, there's a scheduled written briefing in September. We are due to schedule some briefings from the Minister. So it might be an area that members might want to take up with the Minister around that period before.
Certainly, there seemed to be a suggestion that there won't be a winter preparedness plan from now on, that it will just be surge planning, is my understanding, and I think it was referred to earlier there as well. Now, I appreciate that it is an all-year problem, but they're acutely raised during the winter months.
It kind of arrived in autumn this year, didn't it? Which maybe threw them in their winter preparedness plan, because that flu that arrived about the sort of October time kind of led to a massive backlog of services round about October, wasn't it?
And in fairness, and with regard to what we heard today about the neighbourhood model, it's eminently sensible that they look at how we can, particularly if we're looking at elderly people, we roll out a more refined vaccination service. I think that's a good suggestion. So, I mean, we'll just leave it. The Minister will be scheduled to come, and that's a subject that'll be on the agenda.
If members wish for that specific subject to be discussed at that briefing.
I think it wouldn't be unreasonable, and it would be useful exercise to have a post-mortem on why the last year's preparedness plan failed. There may be reasonable explanations, and we'll say dead on, that's fine, but equally there may have been genuine failures, and so it would be interesting to hear what the department would tell us as to why the things turned out maybe so poorly.
Okay. Item number 11, correspondence. So, members, as always, correspondence in the main pack is page 185. There's an index at 187. So, a couple of things just to point out. So, there's correspondence from the Department of tab 11.3, page 193, regarding ADHD services for children and adults. If anybody has any commentary, I'll just open up this. Danny?
Sure. And I appreciate the Minister said that these are estimates, and we have to appreciate that they are estimates. I think it's just a prevalence rate times the population in each trust, just basically a GCSE sum. Guessing, where this is. What I would like to know is if we could ask if shared care arrangements, if we could ask if the department knows how many shared care arrangements have been requested, because these will be people who have found a diagnosis of ADHD and are on medication for it, and have approached their GP asking about a shared care arrangement. So it might give us a better flavour of how many people with ADHD diagnosis are out there looking for a shared care arrangement. Thank you.
Yep. Okay. So there's also correspondence from the Department of tab 1110, page 230, regarding EY immersive experience for officials in government. I'm going to propose we note that. Not sure it's relevant to the Health Committee. So there's also correspondence from the department in table pack, page 1126, page 30, and it's regarding the PATH project and the economists within the department. So it's kind of a mix and match of two things, and Danny did raise it during the previous section. So first bit of it is a response in relation to the visit that we had to the Mater Hospital and that service, and then they've tagged on, because we did ask a question about health economists, and I agree with the line Danny was pursuing. I think the Department of Health should have health economists, because just looking at numbers is all well and good, but health economists can look at a wider picture in terms of, if you do the outcomes, patient outcomes of B might actually be better, as opposed to just you save money. So anyway, it's there if anybody has any commentary on it.
Do we know, are there no health economists?
No, there's not.
We knew there wasn't. It was just, he wasn't saying it. It was like somebody,
no.
We have economists in health, but they're not health economists.
Yeah, they have economists. So no, they did respond in this letter to the fact that there was no health economists. Yep. So Danny was asking a question he knew the answer to.
You should have told
Those are the best questions they ask, by the way.
Yeah, okay. The other item then, just page or tab 1137 is from extern. So I mean, they have written to us on the back of a visit that me and Danny did with them with regard to the future of the needle and syringe exchange service. So this is in Royal Avenue in Belfast, and because Belfast Council is regenerating that area, that whole row of buildings are being knocked down. So they are struggling to get suitable accommodation. They're engaging with the council. I mean, I think what they're providing is an absolutely essential key service. So are people content that we write to the Minister, the Belfast Trust and also Belfast City Council just to express our desire that there's urgent engagement to try and resolve the issue and find suitable accommodation?
Absolutely. I just wanted to highlight one thing with that, and I thought the visit was very informative. You know, they told us they see over 100 people a day, which is a shocking number, and these people, without that service, they would not, you know, they would be very much at risk. I think the report that they give us as well, you know, highlights that they prevent hospital admissions, they prevent pressure on A&E departments.
What's the issue with finding somewhere? Is there I mean, I genuinely don't know the issues, so...
I mean, I suppose that they have to find a location where what they do is effective, and that's in the city centre. So it isn't an issue where there's money. You know, this is one issue where money isn't an issue because they get funding and they provide a service. I mean, it's also putting in risk their homeless service, which is a couple of doors up. So it's just about finding suitable accommodation. So... I mean, and it might be an issue that we all kind of reach out to our councillor colleagues on Belfast City Council, because I'm not even sure if they're aware of the issue. Okay, are members content then with the index as all the actions? Okay. Yep. Forward work programme, can I refer members to the draft forward work programme at page 700? Are we content with the forward work programme? Keith, is there any comments you want to mention?
Just to say, Chair, we have the informal meeting with the General Medical Council on Tuesday at 1 p.m. in the Senate, and then also the Balmoral show is next Wednesday, and the committee slot is 12:30 to 2. We do have wristbands for all members. We will hold on to them the early next week rather than give them now.
You don't trust us.
Well, we'd lose them then. We'd lose them.
Log them online, Dan.
I've been made very clear that if a member or anybody loses their wristband, they pay on the day.
There's a level of distrust I'm happy to accept.
So we will get them out to members early next week.
And can I also suggest that the first person who arrives at the stall sends a wee location map to everybody else? Just joking. Okay. Happy with that then. Any other business?
Could I raise something, Chair?
Yep, and then Dan, you're going to raise something.
No problem. Concerned recently, now I've heard from a lot of healthcare staff about the implementation of Release to Rescue, which was a policy we heard about a couple of weeks ago. It's been implemented to reduce ambulance waiting times. Now, absolutely, ambulance waiting times are horrendous, and you know we do need to act on that. I've heard from staff in hospitals that are very, very concerned that it's moving the problem onto wards, because they're effectively moving patients from A&E straight onto wards and effectively increasing corridor care. That patients are being moved into already overcrowded areas so that they can create a space for somebody to come in. I just think that Release to Rescue is something we should be keeping a very, very close eye on, and asking the Minister for an update on the impact of it, and how it's impacting on the wards particularly.
Yep, we'll borrow that. Yep. Yeah.
Just on the other side of that, sorry, just that issue though, I had a constituent that fell at 9:30 or 8:30, 9 o'clock last Thursday evening, I think it was, and they were under significant pressure, but the ambulance was there within 2 hours. I've heard many stories of 6 hours, 7 hours, 8 hours, 10 hours trying to get an ambulance out, and that was a an 88-year-old man lying in the garden waiting on an ambulance. So I take the point exactly the one that you're making, but I think it's about pumping additional resources in to help there. But those ambulances need to be out in the community, or otherwise people are left in their moment of need. And there's a story beyond that was even more horrible than that and didn't have a good outcome for the person, as in lights out, and it's as a result of not being able to get ambulances out to people. So again, the rural constituents know what it's like waiting long times, but we can't just pass the problem on. It has to be adjusted as well.
Grand, I'll deal with it another time.
Okay, fair enough. Okay, item number 14, date, time, place of next meeting. Next meeting is room 29 on Thursday, the 21st of May.
Yes,
So we're not meeting next week. Meeting adjourned
for 6 hours, getting shoved in and piled up.
16:59 again.
Committee room 29. Sound. 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 Committee room 29. Sound.